Evening, everyone. Thank you for joining on time, and I really appreciate your dedication to the program, and that actually motivates me to keep myself ready and updated and prepared for this session, because I know it's going to be a very interesting, enjoyable, and a lot of learning in this session. So today's topic of discussion is, how do you go about handling uncooperative patients? I'm sure in your practice as a clinician or as a administrator, you all must have seen situations where either the patient or the family is not cooperating. So if I may ask you, can you just name a couple of situations? I don't want to go into the detail right now, but if you can just kind of list down the kind of situations we all experience with uncooperative patients or uncooperative patient family members. If you want, you can unmute and speak, or if you want to write in the chat box, both are okay. Like for example, yes, please go ahead.
More than the uncooperative, what I meet is something called the collusion. In cancer, the family generally come ahead and tell us, please don't tell anything. We are not revealed anything to him. See to it that nothing is told. So we have to start counseling them first. Then we tell them that it is actually counterproductive. So that is
so I think that's a very important aspect of communication, where the family says don't inform the patient, or sometimes the patient says don't tell my family. For example, if the patient is HIV positive, patient says don't share this information with my spouse or with my family. So these are all very tricky communication. We will cover this when we will talk about breaking bad news. So there usually it is the family who says that don't share the information with the patient. We will see how we have to handle. I'm sure you all must be already handling it very effectively, but we'll learn from each other's experience. So if I may talk about one or two situations. For example, you ask the family to arrange blood. So we normally see they don't want to donate blood. They say, we are ready to buy, but we don't have anybody to donate blood. Or for example, when you ask the patient to move to another hospital, saying that we don't have bed, or we don't have ICU bed, or our hospital doesn't have those facilities. So sometimes you will see that they will not agree, they'll become aggressive with you. I'm sure something like this you must have witnessed in your practice. Am I right?
Yeah.
Yes.
More about Jehovah's Witness. Jehovah's Witness, they will not allow to.
They don't allow blood transfusion.
Yeah, that's also there.
Dr.
Lata raised her hand. I think she wishes to say something.
Yeah.
Go ahead, please. Yeah.
We usually, when we get stroke patients, so the initial few days when we tell the importance of Riles tube feeding, that is very unacceptable for the bystanders actually. So it's like they just don't agree for it. So most of the time what happens is, sometimes we have to get a written statement from that we are not willing for Riles tube insertion, because the patient will be most of the times drowsy, can't take decision. So because of that, after 1 or 2 weeks later, they come with pneumonia, aspiration pneumonia. So that is one problem. Uncooperative bystanders.
Aspiration pneumonia. Yeah, I completely agree. So I think that's a very, I don't want to use word interesting, because that's not the way we should be talking about patient's condition, but that's one of the very serious condition where patient family don't understand the significance or the indication of Riles tube, and then it becomes, difficult to strike conversation. So I think we could do a role play around it if you want, or let us listen to Dr. Mini. I think she also has a case to discuss. Yes, Dr. Mini, go ahead, please.
Yeah, today also I had a patient who was having on admission platelet. She had come for delivery. Now her platelet was very low. So I asked her to get the platelet transfusion ready, get the donors, but they said no, they are not willing. They don't have bystanders. You get it from the blood bank. Of course, the blood bank doesn't have prepared. The platelet has to be prepared separately, unlike the whole blood transfusion.
Yeah.
So they got irritated and they want to go take her to another hospital. Okay, I told, okay, you can take their opinion also, but this is the routine we are doing here. You either you get cold blood or you get platelet transfer, this platelet donated from several donors together, or you can have that component therapy in blood banks. We are having the cancer center, Malpa Cancer Center here. So they went there also it is not available. So it might take time. So meanwhile, they wanted to take her to another hospital. I said, okay, fine. I don't have any problem. You take it. I will call the doctor there and do the needful. By the time I called that doctor, they said there also it is not available. If the bystanders should bring the donors, then only we can get it. So finally, they decided not to go and remain here, and they will get by blood banks, and the voluntary donors were made ready. And finally, they are now around the needed platelet around 12 units is being being made ready. So that's why I have been to the hospital. And now tomorrow morning I have to give them and then start the delivery process.
So ultimately, could you cordially resolve this? Or was it just because they did not have an option, so they agreed to stay there?
No, they were convinced with what we have talked to them. And I had a decision also in the routine, in the conversation with them. And he also explained the problems and the thing. Then the staff also told them. And finally, they were willing to be here only. No, not out of compulsion or any other problem.
Okay. So for example, these are common situations we all face when the patient party is not, understanding our point of view, although whatever we are doing is in the patient's welfare or interest, but then sometimes they are not ready to see, or they are not able to see our perspective or our point of view. And then it becomes sometimes, difficult to prepare them or to help them understand why we need to do this and how we need to do this. So today's topic, okay, I think I'll mute Dr. Muni's. So the topic of discussion is, let's learn how do we handle these situations. All of you are very seasoned. I'm sure you must be all knowing how to go about doing it. So look at the topic from the point of view that it will give you an insight. Am I doing it the right way? That is one learning maybe we can think of from this session. Second is ultimately you want to transfer this skill to your juniors or your doctors or nurses or paramedical staff, because it is not always the senior doctors who are facing that situation. It will only come to you when everybody has tried their hands and they are not able to handle, and then they ask you to intervene. But then ultimately we want to empower our staff, our doctors, our nurses to be able to amicably handle it at their level and do not escalate every small issue to you and to ask you to resolve it. Then third learning from today's session you can expect is to know your own communication style. So we all think that I communicate very well, and I'm sure we all communicate very well. But then there are some underlying, dynamics and some underlying, ways of communication that probably sometimes even we don't realize how that interfere with our communication, and especially when things are not the way we want them to be. When everything is okay, we all are very cordial, very nice, very respectful. But what happens when things don't move the way we expect? So what happens to our communication? You will get to know about yourself. And then also I have a couple of videos. There are of course my in-house videos. So you'll get to see different ways of handling situations that we all do. Probably you'll be able to see what is your way of doing it, and then how can we make it more professional and more cordial. Because ultimately I think the end expectation from the whole program is that can we create a cordial environment? Can we create a place where we are not at the receiving end, or we don't have to be into this defensive position? And can we get back that way of handling it? That's the purpose of this session. So this is in a nutshell about the session today. So maybe what I'll suggest, let's start with a role play. So we can take any one of these situations that like Dr. Nini was mentioning about a patient who was not wanting to, arrange blood. Or we could take Dr. Lata's case where she said that the patient needs to be put on the ICU tube. The family is just not ready to do it. So whichever case you want to take, or if anybody has any other case that you have dealt and it was very difficult for you to deal, and you want to really understand what other ways could have been, used. Or even I have a case if you want, we could take that case also. Whatever you suggest. What do you suggest, all of you? Which case would you like to work on? Okay, I think I will share a case with all of you because let that be a new case for everyone.
Yeah.
So it's a patient in the ICU and admitted with actually multi-organ failure, and condition is deteriorating. The family wants to take the patient Lama because they are dissatisfied. They feel that not enough is being done, and they feel that if they take the patient to another hospital, maybe the patient condition will stabilize or will improve. So I want maybe two people to be the patient's attendant because we don't want the patient here. Patient is in the ICU. Any two people who volunteer to be patient's attendant. Those who are familiar with the ICU interaction, if you wish to be the doctor, patient's attendant, I'll be happy to have you. Anybody who is volunteering, raise your hand, please, if you volunteer to be patient's attendant. Okay, Dr. Minnie says she will be. And Dr. Manju, you're also ready to be. Okay, that's very nice. So I want somebody who is ready to play the role of the doctor on duty. You could be resident, and don't assume you are consultant because, of course, at a consultant position, you will be far more equipped with how to handle that situation. Plus, patients also treat a consultant with far more respect than the way they talk to the resident. So anybody who's willing to be the doctor on duty in the ICU, please volunteer. Because see, from this session onwards, it's all about role plays because we are going to learn through role plays. Anybody who's willing to, and it's not a very complex situation. I'll share the situation with all of you. What happened? Anybody? It's okay. I don't think it's very.
I don't know, ma'am. I'm an ophthalmologist because I don't know whether I'll be a good resident.
So it's perfectly all right. See, as long as you know how to go about explaining to the patient family, I mean, it's perfectly all right. You know, when the patient family want to take Lama, what conversation we need to make with the family. It's not a very big thing. Anybody? So Dr. Aki, do you?
Yeah, I don't mind, ma'am. Okay.
Okay, so let me share the screen with you and show you all the case background so that we all know what case we are talking about.
Okay.
We'll further discuss what we are going to do. 1 second. So this is the case. You can all read. I think you can see the screen. Dr. Aki, can you see the screen?
Yes, ma'am. I can see the slide. Yes.
So just let me know when you have read up to that term situation, then I'll scroll it up.
Day 3 of admission.
So you could read it to yourself so that others also can read. Yeah.
Okay. Okay, ma'am. Can you please up? Yeah.
So family can read what is their role. Yeah. That we are angry about the overall management of the patient and behavior of the staff and want to take the patient to another hospital.
Okay.
So shall I stop sharing the screen?
Yes, ma'am.
Okay. So this is the situation, and all of us will switch off our videos. Only 3 of you will be, visible to all of us. So we assume that Dr. Rakhi, you are sitting in the ICU, and these 2 patients attendants. So would you be patients' sisters, or what do you want to, how do you want to relate with the patient?
Patient's father and
No, Dr.
Uh,
Rakhi, no.
Daughter.
No, let the attendants decide what role they
Okay,
want.
okay.
Yeah.
Okay. Let them.
So both of you, if you want to play the role of sisters, even that is okay. Daughters or whatever role you want to play, so that you can easily, fit into the role. Yeah.
So it's a 53-year-old man. One can be a daughter and one can be a wife.
A sister. No,
Sister.
she's Sunita,
She's
58, right?
50.
So one can be, she's a female.
So one can be sister and one can be daughter. Is that
I'll
okay?
be the Dr. Mini. What do
Okay.
you want to be?
Any? No problem. I have raised a sister. Okay.
Okay, then I'll be the daughter.
So Dr. Mini, I think there is a phone near you which is ringing. Is it possible to?
My
Because,
phone is ringing.
because of that, we can see something, hear some sound that shows that there is something ringing on your side.
Oh, maybe my fan. I'm in the. I
Okay.
told you now.
So there's a task for
Okay,
everyone. So Dr. Nambiar, is it okay if I request you to switch off your video? Are you okay to switch off your video?
Okay, no problem.
Thank you. Thank you. So for all others who are just going to observe the role play, for us, we have a task. We are going to observe the role play, that we are not going to observe the family, because family can behave the way they like, and normally they are very aggressive and unhappy. But what we are going to focus on is how Dr. Rakhi handles the situation. So we will focus on the way she speaks, what all she says. We'll look at her body language. We'll look at her tone of voice. We'll look at the way she tries to strike conversation. So these are the things I want you to observe and keep noting down. And I'll ask you to unmute and mention what you have observed. But at the same time, I would want you to focus on the good things also, because the ideas we want to learn from the role play. So look at the good things that Dr. Rakhi does, and then of course what could have been done differently or could have been done better. We'll focus on that also. We'll talk about that. So Dr. Rakhi, it's just a role play. I know it appears very artificial, but that's the best way to learn how to go about doing a role play. Because when we, of course, all of you seem to be very seasoned, so I don't expect any challenge that you will face in real life situation. But if you can imagine yourself as a resident, then I'm sure you can relate. It is very difficult for the residents to actually handle these situations in a very cordial manner. Usually, we become upset and annoyed with the situation. But we are not going to judge you for your performance. We want to learn from your performance. That's the idea.
Yes.
So I'm going to switch off my video. Dr. Ambiar, is it possible for you to switch off your video?
Okay.
So how much time do you think, Dr. Rakhi, you need? 2-3 minutes are okay?
Yes, ma'am.
Okay. And if
So we have to talk to Rakhi about the patient. We have to ask, and Rakhi is replying.
Yeah.
Have
So
to
Dr.
reply.
Rakhi is the resident on duty, and you both are patient's family, and you have come into the ICU, and Dr. Rakhi has to, you have to say whatever you have to say, that you are unhappy and you want to take the patient, whatever comes to your mind. And Dr. Rakhi has to handle that situation. My video will be off. I'll only come in case if I have to say something, or when I think we have 2-3 minutes, so we can reply. Dr. Mini, on your side, there is some device that is, kind of in conflict with the Zoom. I don't know. It could be somebody's phone or what it is.
It is my phone only. I'm joined. I have joined through the phone only.
So, are you receiving any call or messages simultaneously?
Oh, maybe.
That's why every time, after every few seconds, there is a kind of disturbance.
Okay. Let me see, madam.
See if you can. Yeah. So I'm going to stop my video and let's start the role play. Go ahead, please.
Because I have a hospital call also in that side.
Okay, I think Manju ma'am can start then.
Yeah, I'll start. Dr. Mini can take the call from the hospital. I'll start. Yeah, okay.
Okay.
Yeah, doctor.
Yes, tell me.
Yeah, Sunita is my mom, and I just arrived today. She's been in your care for the past 3 days.
Yes.
My aunt, her sister was there with her.
Okay.
So I landed today morning and I tried to get some sort of information about her. I tried to ask the ICU staff who came out in between, and no one was responding. No one said anything about her. and now they are saying that her condition is very bad. What is happening, doctor?
See, whom you were her daughter, right?
Yeah, I'm
Sunita's
her
daughter.
daughter. Yeah, I'm her only
Okay.
daughter.
Oh, okay, okay. So when your mother was rolled in, actually she had a gastric bleed, and we did all that we could. And then after 3 days, this is a situation that, her vitals, everything is, it is getting compromised. So whatever we can do best,
But
we are
doctor,
doing.
when I talked to her about a few days back, she was completely okay. I was not with her, and she was admitted just 3 days back. She came walking to the ICU, is what my aunt told me, and no
Yes,
one said
I
her
understand.
condition was so bad.
The thing is, all her renals, everything is, getting compromised. So whatever the treatment that we are trying to give her, she is not responding. So we are
What do
trying
you
our.
mean by that, doctor? She was completely okay before. I think she became worse after she got admitted in your care. What do you mean by she's not responding? My mom was completely okay when she came to the hospital. What do you mean? None of your staff, no one told my aunt any of these details till now.
No, because
All of
you
a
have.
sudden you're saying that my mom is not okay. What are you saying, doctor?
See, what is your name? Your name, your Manju only know your name. Okay. So Manju, just you have to. What I'm trying to say is, when she came in, she had massive bleed. Okay, you are not there. It was your aunt who had brought her in, and she knows better. Maybe you could actually, communicate with your aunt who was
No,
along with.
I was communicating with her, doctor. I was
And
talking to her
I
every day, and she didn't tell me all this. She said my mom is improving. And she also said that no one was telling her anything much. So she presumed that my mom was improving.
when the blood results
No,
were normal at that time, and you said by putting the tube and everything, the bleeding has stopped and the blood investigations were normal. But how did it suddenly worsen? I don't know.
So I think we have still not touched the agenda. The agenda is that the family wants to take.
Lama.
Please,
Yeah.
let's come to the point. Till now, we're just talking about that she's deteriorating, but that's not the reason. The problem is that you want to take the family. So let's start with this, that whatever it is, we want to take the family. Yeah.
Oh,
so the family wants to.
yes, doctor.
Yeah. So the
Doctor,
family wants to
anyway,
take
she's
the
not
patient
improving
away,
and
right?
it's become very.
Sorry.
Hold
Yeah.
on. Let the
So
family
we
come and
have-
come to you and say that they want to take. Then you can start discussing.
Yeah.
Let the family speak. Yeah.
Yes, doctor, we have been with the patient, see how bad she is becoming. So anyway, the situation is not improving and the staff is also not responding. We are better now. We have decided to take her to another hospital.
See, in this condition, what I suggest is, even if you are going to shift her out, she might, on the way also, she could, collapse, and something massive crisis could happen. So I suggest that, we can just wait for another maybe 24 hours or so,
But do
and
you have the
wait.
guarantee that by will improve?
There is no guarantee as such,
Then how can
because.
we keep her?
See, what I'm suggesting to you is, what will you gain after taking her from this hospital now and then taking her to a different hospital? You think, have you spoken to the other doctors? Whether are they ready to receive her and do the needful?
Yeah. Yeah,
Yes, we have spoken to them. They are ready.
Yes.
Okay.
Anyway, we have to, because we are not getting the results, and the staff are also they are not revealing the results. I have so many times I've asked the results and they are not giving me also. They said that the doctor will test,
But
doctor will
that's.
test.
Yeah, but nurses also, they have already told you every like morning, afternoon, night, they are calling your bystanders and explaining to them as to what is going wrong.
They are not
I mean-
letting to see them also. Yeah, they are not letting us to see.
See, we are not,
not letting us see
we cannot allow every person to come into the ICU. You know,
It's not every person, doctor. It's just her sister and her daughter. We definitely have to see her. And anyway, we have decided to take her to the other hospital. We can't risk her life further in your care.
so now what do
We
I
are not
tell,
satisfied
ma'am?
staff also. They are not. They're not showing any sort of empathy towards us. When we ask them, they are not giving the proper answer also.
Can I request
What
everyone
medicine
to
they are
come in?
giving, what they.
Can I request everyone to come in?
Hey, Raki, sorry, Atta.
No problem.
So we have to actually thank Rakhi to have taken that,
No,
challenge. Yeah,
I'm cornered. I don't know what to say.
I told you right in the beginning that, see, at least if this gives you all an idea, if you are, 10, 15, 20 years experienced people, if you have challenge handling attendants like this, imagine your residents, if they don't know how to really go about handling it, how difficult it must be. So anybody else who is willing to, somebody's phone is ringing continuously. I don't know whose phone it is. Some message or
Dr. Minis only.
maybe. Yeah,
These two devices are on.
I am
No,
switching on
I
to
think
my
messages-
laptop because I am on. I am
Messages
on
are
duty.
coming to her mobile. That is
actually, she's on hospital duty. She informed
Yeah.
me in the beginning that she'll be joining from her mobile. So it's
I will
okay.
switch on.
So
I will
Dr.
now
Mini,
change.
keep it on mute mode. That's all. That's all. But don't switch off your video. Please have your video on. Keep it on. Okay. So anybody else who would like to take Dr. Raki's place and handle this situation? Okay. Dr. Lata has raised her hand. So Dr. Lata, we go back to the same situation. Now you are playing Dr. Raki's role, and family, two of them will remain same. Is that okay? Okay. So can I
think we
request?
should be more aggressive.
That's okay. I think let's keep the difficulty level to 4 and 5 right now. When we will talk about aggressive patient party, then we can take aggression to the level of 7 and 8. But it's okay for the time being because we are beginning, so it's okay. So I think I'll ask all others to switch off their videos and let only 3 of them. Situation, Dr. Lata, you know,
Yes, ma'am.
and the family knows the situation, and they have to now. Dr. Minnie and sorry, who was the other doctor? I'm forgetting. Please come.
Manju.
Yeah, Dr. Manju. Yeah. So please come in as the family. Dr. Sonia, can I request you to switch off your video? Yeah. Dr. Minnie, are you there?
Is it the same scenario, ma'am?
Same scenario. What we are trying to see, can it be handled little differently? That's what we are trying to. You both
Yeah.
played your role well. And Dr. Manju and Dr. Minnie, you played your role well.
I have faced the situation, ma'am. That's why people have said this to my face.
I know. So it's okay. I think by the time Dr. Minnie comes, we can start the role play. Imagine that Dr. Lata is sitting in the ICU and both of you have entered the ICU and now you strike conversation with her. Go ahead, please. Yeah.
Hello. Yeah, hello, doctor.
Hello, tell me.
Yeah, you're the one who's taking care of my mother. I think she's Sunita,
Yes.
and she's admitted in the ICU. I'm her daughter.
Okay.
I wasn't here. I just arrived today. And they tell me that her condition is very bad. My aunt was here with her for the last few days when she was admitted under your care.
Yes.
So how's her condition now?
Actually, now her condition is really bad. Her all organs are failing. So when she came, she had come with jaundice. So she already had mostly some liver problem. Then she vomited blood. and there was some bleeding, gastric bleeding when we did an endoscopy. And then her BP and all has fallen. So after that, she developed renal failure. So her condition is really bad now. She's on ventilator. And in this situation, we are giving her all the supportive medications, medicines to increase her blood pressure, ventilatory support, everything is going on.
No, but how is she really now? You have said a lot of things. How is my mother really? How is she?
She is comatose. She's on ventilator. That is artificially we are giving her respiratory support. All
No,
her.
but you didn't say all this earlier. My aunt didn't tell me all this. She said she didn't say all this. This is all news to me.
But when she had come with jaundice. So after that, she
But
developed.
now she's not recognizing anyone. That time, everyone, she was talking, she was seeing us and she was talking to us very friendly, and she was eating, everything was okay at that time. Only thing, she was vomiting because of the jaundice. And now you are saying it is all bad.
Yeah,
Within 2 or
sometimes
3
what
days.
happens is because of jaundice, she may develop altered sensorium. So now she has reached that stage. That's
But why didn't anyone
why-
tell us all this before?
Why didn't you
anyone
give the
say-
proper medicine at that time? Why did you make it so complex now?
No,
Have you given the proper treatment? Have you done the proper
as and when-
investigation?
Yes, yes. As and when the problems were arising, we were giving her all the symptomatic treatment for whatever crisis was happening at that time.
Symptomatic
then you
means,
didn't
did
tell
you
us,
have a
you were not-
diagnosis that time? What is the
That
proper
time-
diagnosis?
That time she had come with jaundice. Jaundice could be because of many reasons. So investigation is going on, but along with that, she developed all these complications.
No,
doctor,
even
my
our
mother came
neighbor
walking
says
to the
you can have.
hospital, and now you're telling us that she's so bad. No, I'm not satisfied with the way that you're taking care of her. None of you, neither you nor your staff, no one informed us of this condition of hers. We want to take her to another hospital. We can't leave her here.
Even
can't take the
my
risk of
neighbor
leaving her
was
here.
saying, yeah, my neighbor was saying they had a similar problem and they went to some Ayurveda, they got some kashaya and all, and it went all very well, and they are now okay. Now here we brought her for better facility, and now you are saying she is comatose.
Okay, because of jaundice, she can develop all such complications. At present, we are doing everything for her. But if you want to take her to a higher center, we can, whichever hospital you want to go, we can call them and communicate her present status. But whatever treatment is required in this present situation, we are giving her.
Yesterday, but I talked to them, but that time they said that you didn't say that it is so serious. And even the reports I asked to discuss with another doctor, they said only the doctor will give, and you should ask the doctor. We are paying for the reports, but you are not giving from the lab.
Reports, actually, we can give a summary if you're going to another hospital.
Thank you, Dr. Lata, for trying your hands on this. Thank you. I know I put you on a tight spot. Can I request everyone to come in, please? So we'll first focus on what went well. First for Dr. Rakhi and then for Dr. Lata. So what do you think they did well when it comes to handling this situation? We'll talk about Dr. Rakhi first. What do you think?
They explained calmly.
They explained calmly. Okay.
They didn't get angry.
They didn't get angry.
They did not get.
Was polite till the end.
They were polite till the end. They did
They
not.
they didn't get provoked.
They did not get provoked. Wonderful. What do others say?
Yeah, she did tell the risk of transferring now would not be worth it.
Yeah. Dr. Rakhi did try to explain that if you will move her, she asked, what will you gain? What will you gain by transferring? So it's the words that I want to really focus on. How will these words impact the family? We'll talk about that. Anything else that you think? Okay, Dr. Lata, what about Dr. Lata? She did a lot of good things. So what do you think she did well?
He explained the measures that were done so far.
Yeah.
In detail.
She tried to explain what exactly, how situation has deteriorated and how this can happen in case of jaundice and what is being done. She did try to. So as a system, I think what could have been done to not to get to hear these kind of statements coming from the family that you didn't inform her, she did not show us the report, nobody explained to her, nobody informed her. As a system, what mechanism can we put in place to
We'll
ensure?
Give an update every
updating.
It will be good if you raise your hand so that I know
Yep.
who's answering. Yeah. Okay. So, Dr. Harimo, yes, raise your virtual hand, and I can call
yeah,
you.
sure. We
Yes, Dr.
definitely require updating the patients. That is
Yeah.
a must, especially in ICU. There should be a system for that.
Absolutely.
That's it.
Absolutely. I think
That is a must.
this
And
is
it is-
one thing we have to emphasize, that they must, update the family on regular basis. And it is not the nurses who are going to be updating. It is the resident and the consultant who is supposed to speak to the family. And yeah. Yes, Dr. Sanjeev, you have raised your hand. I want to hear from you.
A register can be kept in the ICU so that once after every briefing, that attendant can be made to put her signature so that there is a proof.
Absolutely. That's so very important. See, every time they said that we have not been informed, doctors are saying, yes, we informed you. If you are updating and if you document that this thing has been shared with the patient's family, and you sign, and the person to whom you have, explained, if you write their name and ask them to sign, that's a good evidence. Normally, we don't think that that would be required, but then that is so much of a safety measure to prove that we have been updating the family on regular basis. I completely agree with you. I completely agree with you. Any other point? Yes, Dr. Mini, you have
Yeah, we can write the name of the bystander who has heard it and so make them sign. And whenever, whatever high risk we are telling, suppose the patient has some complication, etc., get
Yeah.
that informed consent written on the case sheet and make them sign on it, so that next time when they come, another bystander come, we can show them that this has been explained to this person, and the relation of the patient to the bystander, to the relation of the bystander to this patient. That
Sure.
also, because every time we cannot communicate with each and every relationship relatives who are coming there. So
Sure.
the prime relatives, the main bystanders has to be assigned, because morning I'll be talking to one person who is supposed to be the father. The next evening, the husband will come. He say, we have been searching for you. I didn't see you. And now another person will come, say, you have not explained the seriousness and all. And
I
when
get
the
your
things,
point, what you are trying to say, Dr. Mini, that getting this signature is a very good idea so that we know whom we have talked to, and that acts as an evidence also. Thank you. I think that's a very good point. Yes, Dr. Shivkumar, Dr. Vasudevan, you want to say something?
Yeah, the most important thing I would say is to have a specific time. When you should tell that, okay, between 9 and 10 in the morning, I'll be telling, between 4 and 5, I will be telling. So then whichever bystander, whoever is there.
Actually, outside the ICU, if you have a board displayed, that family will be updated about the patient's condition. This is the time for the family updation. That's good enough for everybody to know that.
Everybody will be there, and you can explain it. And you should have exclusive, like an area where you can sit and explain to them. That is very
There should
important.
be a kind of
It
counseling.
should not be just here that he just comes out to the ICU and people surrounding you, and that is not the way.
Completely, I agree with you. There should be
a secluded area where they can show their emotions, where they can explain to them.
That's a
Where
very
you can sit down and explain things to them. Sitting down is a very important aspect.
Thank you. I think that's a very good point you have made. Thank you. Yes, Dr. Paul, I think you have something more to add.
Yeah, one thing's already been mentioned by Dr. Shivkumar Vasudevan. It's about the counseling room. And second thing, they should know, we should try to explain why they are not why we are not allowing to the ICU because of the infection part. And that should be made clear to them. And initially itself, as many has mentioned, that one person should be always be brief. And a counseling room, the counseling room, all others can come and speak.
Absolutely.
So it will be more, actually, we will build more rapport with them. And that will be, and always you should mention, as always, when you greet them, you should greet them, and you should mention your name also at the beginning, so that they will be familiar, and the rapport will be much better.
Absolutely, absolutely.
also, if there is any different plan, or where there's a plan B also, that also should be told to them. And actually they should take a decision should be based on a collective decision, should be between the doctor and bystander, the two plans, and whichever is better, we will be opting like that.
So is it okay if I kind of give you a demo? How can we handle this situation?
Yes.
Yes.
So let both the family members, Dr. Manju and Dr. Minnie, both of you be as aggressive as you were with Dr. Aki and with Dr. Lata. Because we want to learn how do we handle that. So you don't have to spare me. Speak the way you were speaking to them, so that we basically want to learn how can we handle this situation differently. So I request everyone to now note down what I did slightly differently, not because I know it better, but because I've been doing it and I know the background. So maybe that's what I want to highlight. So try to observe what I'm doing and what difference do you see. That's the main learning that I want you to focus on. So can I request everyone to have their cameras off and just three of us be around, Dr. Minnie, Dr. Manju and me. Okay, so I'm assuming that I'm sitting in the ICU and Dr. Minnie, you are coming in front and Dr. Manju is coming after you because you have been visiting the patient morning, evening, both the time. And the moment you have entered in and I smile at you and I say, Minnie ji, आइए आप सुनीता जी की बहन है ना?
Yeah.
You are her sister. Yeah, tell me. Who is this with you? आपके साथ कौन है? Who is this with you?
Yes, doctor. We have been with the patient.
Dr. Minnie, I'm not able to hear you. Is there some challenge at your end? Network issue? Yeah. Yeah. Is everything okay at your end, Dr. Minnie?
Yeah. Am I not audible?
Yes, now you are audible. There was a point when you were not audible. Yeah.
Between,
it's okay. I'm restarting now. So you have.
Yeah, I heard it. I heard it.
So you have come in and I'm greeting you and I'm saying, Minnie, you are Sunita's sister. And who is this with you?
She's Sunita's daughter.
Okay.
Yeah, Manju.
What is her name? Manju. Yes. Aye, please both of you take your seat. Yeah. Tell me, please, what is it about? What do you want to talk about?
The first patient, no, madam. First patient ka naam.
Same patient, Sunita. We're talking about the same patient.
Okay.
Yeah. Tell me, please.
I don't want to sit down, doctor. I want to see my mother. I just arrived now. I wasn't here. My aunt was with my mother. I want to see her. I don't want to sit down. How is she? Yeah, how is she? I want to know how she is. I want to see her.
My daughter is very much worried, doctor. My daughter is very much worried because all the way.
Yeah. Manju, do you want to see your mother first before
Yes, I do. I do want to see my mother.
Perfectly all right. I understand. I'm sure you must be really concerned about her. So, I mean, you take 2 minutes time, go and see her. I would not advise you to stay for very long because, in ICU, we have all patients who are very serious and critical. But of course, I understand your emotions. You can go and see your mom for a minute or so, and then come back to me, and we can have a discussion, whatever you want to understand.
But I think it is better you don't see her now in this pathetic situation. She was very much better when she came here. She was walking all the while, and now she is on the ventilator or something. So many tubes and all with her. I don't want my daughter to see that, doctor, please.
So tell me, what are your concerns, Manju? What do you want to ask or say?
No, my aunt told me my mom was perfectly all right when she came. She came walking into this hospital. And then she was admitted because they wanted to admit her in the ICU because she was not feeling well. And she vomited some blood or something. And then we had no information after that. And now you're telling me that my mother is on the ventilator. What are you saying, doctor?
We thought it was acidity.
So, Manju, the thing is, yes, your mother came walking 3 days ago. She had jaundice for the last 3-4 days. When she came and we did the, she actually, Miniji had brought her with the complaint that she had vomited blood. So we did immediate, endoscopy, and there was a gastric bleed inside. Inside there was a blood in her stomach. Of course, we
They
work.
said only ulcer, some ulcer in the stomach part that it will be healing with medicines and all. That
And
time it
jaundice
was
is
not
such
that
a common condition. How did she get bad so fast? You didn't tell us any of
So-
this, doctor.
so,
We were totally
Manju,
unaware of all this.
Manju
didn't
and
say-
Minnie, give me
bad.
one second.
Jaundice is very common
Minnie,
now.
Minnie, 1 second. I'm ready to address both of your concerns, but then you have to speak one by one. If you both are talking, although I understand your emotions, you're really upset, and I can understand those emotions. But if you really want to understand what is the situation, if you want to see what is being done, then please allow me to answer your question and then we go ahead. I'm ready to give you 10 minutes, 15 minutes time to talk at length about your patient's condition. But at the same time, you have to give me a chance to explain. So what I was telling you that yes, she came walking, but at that time she already was bleeding inside. And unfortunately, when you're bleeding inside, how much of blood has already gone in, that's one thing. Plus that affects your, vital organs, especially the respiratory system, the lungs and the heart and kidneys, all that get affected, and especially the bleeding is nasal. So in her case, immediate treatment was started. She was taken to the ICU. Whatever needed to be done, all those standard treatment protocols were followed. But unfortunately, her condition has actually deteriorated in the last couple of days. I agree with you that she hasn't improved. She's actually put on ventilator. And before we put her on ventilator, we had informed Minnie. We had called her, we had shown her condition, and we had also informed her that we need to put her on ventilator because she's not able to breathe on her own. And I have all the documents to show where we had informed. So if see, we have always tried to communicate directly with Minnie because she is the primary caretaker. But whenever she was not there, anybody who was there, we called in, we informed, we also, I can show you the case sheet, whatever like was
What's
done.
the point in
But
showing us a
that-
case sheet now when my mother
that-
is so ill? What's the point in showing us all this now? We don't want to see all these documents, doctor.
That time I asked for the reports, madam. The staff didn't listen to me. She was not even bothered to talk to me also. Just if I got the result, I would have taken some other's opinion also. And I never understood that it was becoming so bad and deteriorating like this. Suddenly it has become worsened. Yesterday,
So
it
Minnie, the
was-
routine is we every day in the morning and the afternoon, we always update the family, especially when we know the patient's condition is not good. We also
No,
understand the family's concern. In case if you were not there, see, I can show you patient's case sheet. Last evening, I think you were
No,
not there. There was
yesterday
another.
morning only they called me. Evening when I came, you were not there, madam.
Yeah, I was away after 5 o'clock. But see, routine is that we always call a family member and we try to call the same person so that that person knows what we have informed. In your case, Manju, I think because you came now and I understand your, state of mind. I mean, seeing your mother in such a state definitely would be very upsetting.
No, madam, morning she took food, evening she couldn't. That
And now you're telling us that
only
she's
it
so
became
bad and she's on the
Morning she was
ventilator.
eating also, taking
She
liquid.
hasn't taken anything orally for the last 3 days, Vinny. I think if you remember, we informed you that she's not, and she was
Liquid diet she was taking, madam. Some I brought
We
from the
wouldn't have been
canteen,
so shocked if
protein
we
mix
knew
and all.
all this.
So
We didn't know all this.
What
We
are
want
your
to take her
concerns?
elsewhere. We
want
don't
to-
want to
We
leave her
think
here.
we'll go leave some other hospital because we are not happy with the staff also not responding. They're not taking care. I think because of the lack of care only she worsened.
So, see, if you think that proper care hasn't been taken, I'm ready to make a summary of the patient's care or whatever treatment we have, given her. You can take a second opinion if you want. I'm open to that.
Yeah, definitely we'll take.
You're more than welcome to, because whatever standard treatment protocol needs to be followed, we have followed that. I can share the report if you want to consult somebody. And regarding your wish to take her to another hospital, I would not stop you from doing that because it's your call. She's your patient. But at the same time, I can tell you that moving her in this situation from one hospital to another is actually taking a risk. For example, if you will move her from here, you will remove her ventilator. First, you will have to find out, are there beds available? Second, if the doctor is ready to take, please take the summary from me, talk to the doctor if they are okay. And if they say, yes, we have something more to add, you are free to
No,
take.
mobile with ventilator is there. I will take it that.
Yeah, that's what I'm saying. But moving from one bed to another bed will take at least 4 to 5 hours for you.
If you
Keeping your
keep there,
patient
you have any
updated.
guarantee that she will escape from this?
Absolutely no. I cannot give you any guarantee, but I can assure you whatever treatment needs to be given, that is being given. You can check with the doctors where you want to take her. Check with them that have we failed anywhere on the treatment.
Okay, then
And in
give
case
us a
if they have
report. We'll
something
see.
more to it, I will not stop you. She's your patient. I would be more than happy to help you. You want to see her alive, even I want to see her alive. But
Yes, doctor,
moving
but-
her will be risking her welfare.
But
You will be
suddenly when
moving-
it all becomes bad, we are not that, we are very much worried, doctor.
That's what I'm saying. That's what I'm saying. Please discuss with family. This both of you go and sit and discuss with your family. If you want to still move her, taking that risk, because you will remove from ventilator, you will put her on ambulance, take to another hospital. Once you get bed here, then she'll be put on ventilator again. And I don't think it is safe. But if you
All
still
our
want to
relatives are asking why no, why it is that she's not improving, take her to some other hospital and all. All are
I know.
blaming us, doctor.
see, everybody is concerned about your mother, that I completely understand. But there is a point when you give best of the treatment, but if the patient does not respond to it, that's where your limit, the human limit ends. I'm ready to give you the document, go and consult your second opinion. If you want to move her, you are more than welcome to move her. If you ask my advice, I will not advise you. If you ask me for guarantee, I cannot give you guarantee. Honestly, I can assure you that whatever best treatment needs to be given will be given. But I cannot give you guarantee because I don't want to give you any false hope. And very honestly, her condition is deteriorating. So I can't even say that, okay, keep her for a few more days and maybe things will change. It's completely your fault.
So
And
can you
on
give
my-
me the progress report of the day? Then
I will-
we'll
I
ask,
will.
we'll consult some other and let you know that.
Absolutely.
Until then, let her be here. We'll
Absolutely.
discuss with another, my relative is a doctor. I'll send the report to her and get their opinion also.
If you want, I'm ready to even speak to that relative of yours who is a doctor. That will be really nice if you can connect me with your doctor, because then probably what I say will be better understood by him or her, and then they will be able to explain you better about what we are doing. I'll be more than comfortable talking to your family if there's anybody who is a doctor. Thank you. Thank you so much. Can I request everyone to come in? Was it difficult?
Very good, madam. You did such a
Good.
great job. Manjuji and Miniji became chup. They became very nice people.
We will give you, all of us want to take you to our hospitals.
So communication is not what family communicates. It's how we handle the communication. They will be aggressive. They will be apprehensive. They are concerned. If it was my mother or your mother who was on deathbed, anybody would behave the same way. But can I answer things in a more amicable manner? Can I handle their apprehension? Can I explain to them? That is what we have to learn and teach to our residents now. If I just say, do you know medicine? Do you know what I'm giving? Are you a doctor? She said, I want to go and see the patient. I would have definitely sent her, go. Because when she will go inside and see the patient, she will come out and herself have this clarity. Patient's condition is not good. You will always see family moving their hand like this on the side of their body. And that's an indication that they're having that realization that the survival is very unlikely. It's very important to send the family members to allow to see the patient. We talk about infection, we talk about all those things. Honestly, tell me, how many infection control practices are we really implementing in ICUs and OT and all other places? I myself have gone a number of assessment to very premier institutes where they are in OT or ICU or nursery. They are using the same slippers inside out. They are wearing masks, but they are wearing below the nose. They are wearing gloves and they are touching everything. So where do you call aseptic techniques and infection control? That's just a cover up. So why do we, and especially when I know the patient's condition is so, vulnerable, so risky, allowing the family will give them a chance to at least see their family member alive. We really need to open our mind to these things. And when I allowed her to see, I said, don't stay for long. There are other patients. Don't try to make any kind of noise or movement. Just go and see and come back. They'll
Yes,
be
yes.
always thankful to you that you allowed me to go and see my patient. Now,
Yes,
this patient,
especially,
yes,
yeah,
yes, please, Vinny, go ahead. Yeah.
especially when the patients declining or when they are going bad, we should show them more frequently actually, because then only they will understand.
So, couple of things that I want to emphasize, which I want you to emphasize your participants when you do the program. One is know the family. I repeatedly said Minni ji aiye. I knew my. I'm not saying you have to remember every patient's attendant, but a patient who is in critical condition, I really need to know the family members. First, family member name. Primary caretaker name should be on the top of the case sheet with phone number. Every time I communicate, I have to communicate with the primary caretaker. Like Dr. Mini was saying, morning somebody will come, evening somebody will come, afternoon somebody will come. No, I will always speak to the primary caretaker, talk to them, explain them, and then I'll say, in case if somebody wants to ask something, I request you to talk to them. And in case you want to come back to me, please come back during the meeting hours when we meet or when we update. So in between, there is no disturbance. Somebody comes and says, I want to know about this patient, I can politely say, we have meeting around between 3 and 4. I request you to come at that time. If that person is really very close to the patient, that person will stay back and wait for the meeting time. Otherwise, that person will go out. Plus, updating the family regularly is very important. It is preparing them for the eventuality. It should not come as a shock. Like, for example, what Dr. Minnie was saying, that nobody told me, nobody informed me, ventilator, although it doesn't happen. When we put the patient on ventilator, we inform the family, we take their consent. But if I have that evidence, I'll very politely say, see, we informed whoever was there. Miniji, you were not there. I think there was somebody called Vinod. Oh, yes, he was my cousin who had come. See, we called him in and we informed him that the patient required ventilator. Since you were not there, so we had to talk to him and explain to him. So I should have that evidence to prove what I'm saying is not in here, but I have proof to give you. And then, of course, tone of voice plays a very big role. Whatever you say, if you say in a monotonous, authoritative tone, they feel that we are just, the condition is very bad. We said failing. So if I say failing, I mean, we have to be very careful with words. Sometimes words also do more harm than doing good. Collapse, massive. So again, these words are very huge for the family. So I hope you could find some difference, some changes, some points to take home. How we can make the whole conversation, more cordial, more empathetic, more one-on-one than just sharing the fact. And I was open to the idea of giving the summary. I was open to the idea of talking to the doctor if they have a doctor in the family. So these things really help family have confidence in you. When they say, this is my brother, he's a doctor in the US, we suddenly become very annoyed. Why the hell should I speak to your brother? But if you spoke, trust me, half the battle is already won. What is the harm? There is somebody miles away, they want to know about patient condition. If you tell them, they will speak on your behalf and explain, the doctor is very nice, they are doing their best. I don't think we should move the patient. You just cooperate with them. Was it anything artificial? Maybe sorry?
A lot of empathy was there. You were trying to put yourself in their position. You were repeatedly telling them that I understand how you're feeling. And then you were also very matter of fact when you're quite firm. Like if they're asking for a guarantee, no, they will not be giving a guarantee. You weren't mixed up with that. And about the medical facts also, you told very precisely. And they have the right to go for a second opinion. But transferring is a big risk. So everything was portrayed correctly. So, and also talking to the doctor concerned. That is a very good move, I think.
So maybe we are not already doing this, or maybe already you all are doing this already, but I think this has to trickle down to our residents where they know they can handle these situations. They are the one who are the frontliners. They are the one who are handling these situations.
But
And
the
they are the one-
attitude towards the residents and the head is quite different, madam. When the head comes and speaks, it is quite different. They will be little more submissive when talking to the head. Now, unlike the residents.
So again, one, I always request consultants never to embarrass your residents in front of patients, family members. Rather build their image. Tell them that this resident of mine is very hardworking, very dedicated, very responsible. So they will automatically have trust. It's an activity, trust building activity.
Yes, even the staff also.
Even the staff. Trustees also. Oh yes.
Because
But
we should not take their tell their mistakes in front of the patient.
Okay.
Move to some side and then tell them in without letting others hear that also.
Absolutely. Absolutely. Thank you.
That is
Yes,
what
Dr. Asha, I think you have something to say. Go ahead, please. Yeah.
Yes, what we witnessed was, ma'am, when the patient's relative starts blaming or becoming aggressive, the first step we take is defensive. Each of them said all defensive steps. What we did was right and sort of defending. Whereas when ma'am did it, the main change which I observed was you were stating the facts properly, but you were with the patient rather than defending yourself. Like when they ask for a second opinion, yes, I'm with you. Yes, we want her alive. You want that? I also want that. Everything aligned with the patient rather than being defensive. So once we are the treating doctor, they say somewhere subconsciously we take the blame on us and start defending ourselves, and that is where the mistake starts. I thought she is an expert on that, doing the communication. That's what the main change I noticed to us. That's why
and also ready to give the reports also as and when asked. Oh, I will show you the report. I will show the progress report.
Normally, when somebody says this, we start doubting our own, capability or
capacity,
our capacity, which is not true. Actually, patient is not doubting my capacity. Patient wants to be sure that the family wants to be sure that whatever treatment my patient is getting is the best. And even why want that? Why not? If I'm not doing something for the patient, and if I get to know, at least for my all future patients, I can make sure that I do even this. Why not? Why not? The moment you will say I'm open to it, they will more likely believe you, and they'll say, no, I think it's okay. If you give us the report, we'll take opinion. They'll say, no, we talk to the doctor. They say whatever needs to be done is being done. So there's no point shifting the patient. Most likely. So sending the patient away is easier. Especially in government sector, we say, go. If you want to go, go. But that's not the thing to go. We need to speak to them, talk to them, explain to them, and then see are they still wanting to go. Then you say, I'm more than ready to cooperate with you if you want to go. We will help. And I wouldn't say if something happens to your patient, don't blame me, and you'll have to sign a document. I want you to complete that part. I did not do that. I would have said that, see, if you want to take the patient with you, you will have to sign a document. There's a document called, left against medical advice. So we won't advise you to move the patient. But if you still want to move the patient, you will have to sign that document. So attendant might say, no, I won't sign. See, I understand you don't want to sign, but that's a legal formality we need to, complete before we release the patient. So you'll have to, then she might say, I'll call my MLA, I'll call my, somebody from the, please call. I know that person very well and he knows me very well. And it's always good to have good rapport with your local politicians. Yeah. Dr. Lata, yes, you want to say something. Go ahead, please. Yeah.
No, I just want to add that sometimes what happens is residents, the bystanders will be more, they have rapport with the residents. So if the resident build a good rapport, then sometimes some of the things they won't be telling the consultants, they will speak to the residents. I just wanted to add that point.
Depends on how they interact. Yeah.
Absolutely. So I think this gives us some idea that things can be changed. So you have to be a good role model in front of your residents, nurses. If your conduct with the patient and the family is good, it automatically trickles down to everybody working under you.
Yes.
There's a saying, Jaisa Raja Vaisi Praja. The day your mood is not okay, trust me, at home, even your dog will not behave well. Your kids will not behave well. Your life partner will be upset. That's how, you radiate energy, you release energy. At the workplace also, all of you can introspect. Those of you who have good work environment, and if you treat your patients and family members with respect, your staff will dare not misbehave with your patients. They would know that you will not spare them. But if you have a tendency to be rude and authoritative and arrogant with your patients, then don't expect your staff to behave well. So maybe in front of you, they will not misbehave, but in your absence, they will be double your form.
How do we document it, madam?
So documenting is like, for example, I have explained you the patient's condition and I am advising you not to move the patient. But if you still want to go, I respect your decision. I will be writing this in the patient's case sheet because that's the requirement. And you will have to sign a document also that you are taking the patient against medical advice. I'm writing it, I will be signing it, and I request you also to sign it because that's like a document we need to create. That is one of the formalities we have to come.
Can we record the discussion?
Usually, most of the good hospitals have counseling rooms where they have CCTV recording. You can inform the family that whatever they may try to have a camera in their pocket or here or there. You can say you need not record it. It's being recorded. So whatever you and I say will be already recorded. If you want, I will give you the recording. So mostly they will be at peace. Okay, we are under video recording.
They will be recording even without our knowledge.
Yeah, mostly they
most of them are doing that also.
They will be doing it. But that's what I'm saying. We can't go on fighting on these issues. This is an endless game. On the contrary, building rapport is far more easier and simpler. Build their confidence and they will be with you. We actually have started going for, what do you call them? Bodybuilders and all those you have in the bouncers.
Bouncers.
Where all can you have bouncers? Maybe in emergency.
It's not practical.
Can you have it in ICU? Can you have it OT? Can you have it outside labor room? Can you have it in wards? It's not possible.
Casualty.
Yeah. I think only in emergency medicine you have it, casualty. That's all. But what about other areas?
All vulnerable areas.
Absolutely. So, okay, moving ahead with the discussion. So that was just to give you a feel that this is how we can, handle differently. And again, thank you, Dr. Lata and Dr. Rakhi, to have taken that lead in doing the role play. It's a very difficult task, I know, and I put you in that right spot because I just want to give you that feel that, see, if you have difficulty, your resident will have 100 times more difficulty than you. Work with them, empower them, teach them, train them, mock exercise, whatever you can do from this role play. Please do this with them so that their inhibition goes down. They learn how to talk. They learn how to convince. Yes, Dr. Harimon, I think you wish to say something. Please.
I just wanted to ask you, are we very sure that all cases of violence and aggression against doctors are because of lack of communication? If we put a study, it is not so. There are incidences where the communication had nothing to do with it.
I agree.
Yeah.
So there, I think protection is also required.
Sorry?
There, I think protection is also required.
Absolutely. So when we will talk about handling aggressive patient party, there you will see there is this point where no communication works. There you have to just, take safety and security measure for yourself and for your team. But lot can be prevented. That is what
I understand. I agree with that.
If you are able to prevent 8 aggressive reactions out of 10, I think it is more than, and plus, please remember, one aggressive reaction successfully done by them sets a precedent for many others.
Yes.
But if
there'll be series of
if you are able to,
once it happens, there'll be series.
Absolutely. But if you are able to demonstrate that through effective communication with proper counseling, you can handle situation, you can de-escalate. I think that also sends a message around that, okay, communication plays a role.
Madam, suppose you have already, given the update and have it signed by the bystander. So how do you Do you become a little aggressive when you tell them?
See, again, this what I'm going to talk is little more about assertion after this. Assertion comes with lot of practice, But once you will learn this is something like learning swimming or driving. You will never forget. This will become your way of handling situation. I'm not saying that in all 100% situations you will not become aggressive. Again, if you are able to control yourself in say 7 to 8 situations out of 10, I would say wonderful. Because it's not just you not being aggressive, you're setting an example for your team, for your residents to learn. So I do a lot of program for LNJP Hospital. As I said, I work with Maulanas at Medical College. For the last 10 years, I'm working. So their faculty, participates with me when I do the practice sessions with the medical students, especially handling aggressive patient party, breaking bad news, disclosure of medical errors. All this we are going to do in the next sessions we are going to do. So they come back and tell me our handling of patients have changed because what we are doing in the role play, we have started applying in our practice. They are, and many of them, would call me and tell me that this thing happened. You remember that case that happened recently in Delhi, where a preterm baby was handed over to the family as dead fetus, and then later on, and the family became aggressive, and so the head of the department, gynae, she spoke to me over phone and she told me that I handled it, and she first asked me how do I go about handling it. Then we discussed, and I said, okay, talk to the family, make them understand, explain them why you thought it's a dead this thing, and even if there's a moment, that doesn't mean that the child can actually survive, because the survival is absolutely, almost impossible. But you have to strike conversation. Running away will not do, blaming will not do, targeting somebody will not do. And that's what she exactly did. And she reported, she said, I could handle the situation in a far more effective manner. So this is the journey, I would say. So we all handle situations in 4 different ways, if I may say, especially when it comes to difficult situations. One way is where we are unhappy, but we don't say anything. For example, Dr. Mini and Dr. Manju were aggressive with me, and I was just listening. And at the end, I say, okay, you can take the patient if you want. I don't mind. I will tell me what papers you require. I'm ready to make the papers. So this is a passive way of handling situations. But once in a while, if you think you want to use it, it's okay. But that's not the way to handle it. So let me show you a video on this. That how we use passive aggression, sorry, not passive aggression, only passive communication in our patient handling. Give me 1 second to start with it. Dr. Rafiq, can I request you to mute your device?
मैम याद है?
हाँ जी।
मैम बेड नंबर 7 पे पेशेंट जाने के लिए कह रहे हैं।
कहाँ?
दूसरा हॉस्पिटल जाने के लिए कह रहे हैं। उनके जो रिश्तेदार हैं।
क्या कह रहे हैं?
कह रहे हैं मैं डिस्चार्ज करता हूँ, दूसरा हॉस्पिटल जाएंगे।
वो जो उनका बेटा है, जो उनके साथ
जो है ना, वो कह रहे हैं हॉस्पिटल में। एक बार आप फिर बात करा दो। बात से लिसन करो।
जाने दो, क्या करना है, कौन से सफाई करेगा, छोड़ो करो। डॉक्टर राकेश को बोलो उसकी डिस्चार्ज स्लिप बना दे, आप अपना बेड क्लियर कर देना, ठीक है, बना दो डिस्चार्ज स्लिप, बनवा दो। What did you observe in the video? Sorry, it was in Hindi. I'm not sure if some of you had difficulty understanding.
Just
You could understand.
allow them to take passive and just allow them to do it. Jaane do.
Jane do. And you will see this attitude a lot of times, especially, when we don't want to take any responsibility or doing.
Want to avoid their
Avoiding. I think very rightly said, avoiding. So if you use that style once in a while, it is all right. But if that's our regular way of handling, then it is not good. So what is the disadvantage of using this style of communication in our day-to-day functioning?
Bystanders will
Lack of confidence in you.
Lack of confidence.
And we lose the patient clients.
You will lose your patients and clients.
And
It
we'll
can
have a
produce,
bad name also.
litigation.
Sorry?
Can cause litigation.
Litigation and then bad name. Yes,
Bad
Dr.
name.
Menon. Yeah, bad name. Absolutely. Dr. Menon.
The staff does not respect you. The lady who had come, she seemed very unconvinced with regards to the response that you had.
Absolutely. So they would actually lose confidence not only in you, but also the overall system that you are holding. And then, as very rightly said by you, patients will lose confidence in you. They will give you bad reviews. They may go and talk ill about your system. So ultimately, in all probabilities, and this not only in professional setup, even in personal life, if that's the way you are handling situations, people will not value you. People will know that you will not take any stand. So your first score, all of you have your scores with you?
Yes.
So your first scores are your passive communication style score. So can I ask you to write your scores with a comma in between in the chat box? Write all 4 scores in the chat box.
You mean the total score?
4 scores I had requested you to note down. Have you noted down? Yes, I can see.
Yeah, I've noted down.
Yes, I can see some of you have started writing. Okay. Dr. Manon has mentioned, Dr. Sanjeev has mentioned, Dr. Paul, Dr. Rafiq, Dr. Lata, Dr. Deepa, Dr. Manju, Dr. Vasudevan, Dr. Asha, Dr. Zaki. So anybody else who is still left?
Me.
Okay, go ahead, please. Okay. So your first score is your passive communication style score. Another way that we handle the situation, which is more common than not, is Dr. Nambiar, I think your scores are not correct. Not that it is wrong, but probably the numbers that you're sharing is not correct. Just check once again, because you have written 11, then in bracket you have written 3, 4, 1, 2, 1. So you have to write your scores like Dr. Hari Mohan has written or Dr. Rajalakshmi has written. That's how your score should look like. Yeah. Yeah, try writing once again. Otherwise, I'll try to help you. Okay. So as I said, usually we don't take passive stand. We normally take passive aggressive stand. So what is passive aggressive? To look at, we look very silent and quiet. We are not taking any stand. We are not saying anything. We are not making any comment. But inside we are aggressive. We are unhappy. We are dissatisfied. So usually what happens, we carry that anger within us. We don't show it to the person, but we keep that anger within us and we take that back everywhere we go. Again, if once in a while you are using that style, it's okay. But if that's how we are handling most of these situations, again, it is very, very unsafe. So let's watch the second video, which actually displays the passive aggressive communication style.
मैम मैम बेड नंबर 7 के पेशेंट जाने के लिए कह रहे हैं।
कहाँ जाना है?
दूसरे हॉस्पिटल जाने के लिए कह रहे हैं। डिस्चार्ज कर दीजिए, दूसरे हॉस्पिटल जाना है।
कौन कह रहे हैं?
उनका बेटा साथ में जी।
वो जो हर टाइम उनके साथ रहता है।
हाँ जी।
वो है ही बदतमीज, वो देखो बेकार आदमी है, और मगर कुछ ना कुछ उसको नया ही सोचता। अब क्या कह रहा हूँ?
डिस्चार्ज करके हम दूसरे हॉस्पिटल लेके जाएंगे।
तो वहां जाके क्या इनको बहुत बढ़िया कुछ वो मिल जाएगा? क्या यहाँ पे इनको क्या तकलीफ है? क्या कह रहे हैं यहाँ पे, क्या दिक्कत है उसको?
बस हमारे डिस्चार्ज कर दीजिए, हम दूसरे हॉस्पिटल जाएंगे।
नहीं तो वहां पे क्या, यहाँ पे इसको क्या दिक्कत आ रही है? कुछ बता रहा है कि क्या क्या प्रॉब्लम है उसको?
नहीं, ऐसा कुछ बताया नहीं।
कुछ बोला नहीं? अरे ये शुरू से ही ऐसे ही बोल रहा है, ये वहां तंग करने वाला बंदा है, किसी काम का नहीं है। भेजो, ऐसे बंदे से क्या करना है हमने? और लड़ाई करेगा, जितनी देर ये यहाँ रहेगा तंग ही करेगा। कभी मेरे पास आता है, कभी कहते जी सिस्टर ऐसे कर रही है, कभी कहते हैं जी सिस्टर वैसे कर रही है, कभी कहते हैं जी पर्दे नहीं ठीक है यहाँ पे, कभी कहते हैं जी एसी नहीं काम कर रहा आपका। बार बार कंप्लेन ही करते हैं। भेजो इसको, राकेश को बोलो इसकी वो बना दे।
बात कर लीजिए।
क्या बात करनी है? बदतमीज आदमी है, जाने दे, जान छूटेगी। कुछ बोलना मत उसको। उसको कहना ठीक है हम बना के देंगे। डॉक्टर राकेश को बोलो उसकी डिस्चार्ज स्लिप बना दे और बिल क्लियर कर देना अपना। ठीक है, जाने दो। ऐसे लोग जाए ना ही रहे तो अच्छा, सारा दिन से खपाई करनी पड़ती है फिर बस। ठीक है, तुम्हारा क्यों उतर गया? जाओ जाओ जाओ, जाने दो। So what did you observe in this video?
Letting your emotions also, that aggression.
Not talking to the family, not talking to the patient. But at the back, I am talking ill about the patient's family.
Yes.
That he's a useless fellow, he's a troubleshooter, he's unhelpful. All ill words I'm using for him. But I'm not wanting to address
The
the concern or talk to him and ask him, what is your problem? Why do you want to go? Maybe the patient has a genuine reason. Maybe I can resolve that, but I don't want to talk to the family, but I just want to crib at his back. So you will see, even in system, we have people, who would always be complaining or blaming others. People are not nice, society is not nice, patients are not nice, doctors are not nice, nurses are not nice. So they'll have problem with everybody and anybody. So, and they will always be talking about problems and problems and problems. They'll never talk about the solution. So your second score is your passive aggressive communication style score. So you have your scores in front of you. So you can see your scores, and your second score is your passive aggressive communication style score. A lot of us actually show our anger and displeasure directly to the person. And especially if we are in authority position, where we know we can show our position or our anger. Again, that's not a very helpful way, because that's an aggressive communication style. Once in a while, we all lose control, which is all right. But if that's my regular way of handling my staff, my patient, my team members, my family members, my support staff at home and at my workplace, what do you think will be the disadvantage if I'm using anger and aggression very often with everybody?
It will spoil you and even you and your family and all your relationships.
Absolutely. And a lot of us actually have anger issues. A lot of us don't know how to express our anger in a legitimate manner.
Rage.
And at times it comes as a sudden impulsive reaction, which can be very, very dangerous. When we throw things, I've seen surgeons throwing instruments in OP. I've seen people, literally tearing patients' case sheet and throwing on their face. Go away. I will not see you. Do whatever you want. So again, it's a very unsafe way of handling difficult situations, not desirable. Let me show you the third video. and have an idea about how aggressive behavior can look like. Although it's not very aggressive, but yes, this is also the way we all sometimes handle.
मैम आंसू मैम बेड में बस एप्लीकेशन जाने के लिए कह रहे हैं क्यों डिस्चार्ज मांग रहे हैं फिर मैं छुट्टी करके हम दूसरे हॉस्पिटल जाएंगे क्या तकलीफ है उसको तो कह रहे छुट्टी करता हूँ मैं दूसरे हॉस्पिटल जाएंगे यार बहुत ही पागल आदमी है हालत पेशेंट की इतनी खराब है छुट्टी करो रास्ते में कुछ हो गया तो क्या करेंगे उसके साथ जो अटेंडेंट है वो कह रहे हैं कि हमारे डिस्चार्ज उसका जो बेटा है जो उसके साथ हमेशा गया बहुत ही बेकार आदमी है जब देखो इसको पहले तो इतने नखरे इतने हैं कभी एसी काम नहीं कर रहा कभी ये नहीं काम कर रहा अब छुट्टी कर दो छुट्टी कर दो भेजो उसको जरा सही करो उसको भेजो जरा क्या तकलीफ है भाई क्या हुआ है मैम डिस्चार्ज कर दीजिए तुम्हें उनकी हालत पता है इस वक्त क्या है मैं तो हॉस्पिटल तुम्हारे घर के पास ले जाऊं डिस्चार्ज कर दो उनकी हालत इतनी खराब है रास्ते में कुछ हो हवा आ गया ना इधर के रहोगे ना उधर के रहोगे ज्यादा दिमाग मत चलाओ अपना इलाज करवाना है तो शांति से करवाना चाहिए ऐसे नहीं कि इधर भागो उधर भागो इधर आने के लिए अच्छा लगता है और इधर आते ही बहुत ज्यादा भीड़ हो जाएगा पैसे हैं नहीं हमारे पास तो पहले ही सरकारी में चले जाना था यहाँ आने की क्या जरूरत थी आधा अधूरा इलाज करके अब जहाँ जाओगे तो वो लोग तो कहेंगे ना कि ठीक से इलाज नहीं करा उन्होंने मेरा भी नाम खराब करोगे रास्ते में पेशेंट को कुछ हो गया और मुसीबत हो जाएगी आप डिस्चार्ज कर दीजिए भैया बहुत ही बेकार आदमी है तुम डिस्चार्ज तो मैं कर दूंगी बट दोबारा मुड़ के मेरे पास बताना ये कोई तरीका नहीं है इलाज कराने का अपने पेशेंट का भी नुकसान करेगा मेरा भी नुकसान करोगे साथ ही साथ हमारा आदमी है सिस्टर हाँ जी इनकी डिस्चार्ज स्लिप बना दो और बिल क्लियर करो इनका तब भेजना इनको जाओ और दोबारा मुड़ के मत आना मेरे क्लिनिक में पता नहीं कहाँ से लोग आ जाते हैं
You're good in acting.
The ideal and usual most common reaction when the patient
I thought maybe you will throw the pen.
yeah or tear up the paper.
So I think you got an idea that a person who is aggressive will be aggressive with the staff and will also be aggressive with the patient party and will not try to understand or look at things from the patient's point of view. So again, this is something that can trigger, extreme reaction, especially if the other party is very aggressive, or, if they are more in number, or they're really dissatisfied, or if they've been able to find a fault in our way of functioning. That is where the aggressive reaction can trigger. So it's not, I say, it's not the patient who starts the communication. It is we. How we handle that communication will decide the outcome of the communication. So your third score is your aggressive communication style score. So you can write down in front of your score. First was passive, second was passive aggressive, third was aggressive, and the last one is assertive communication. So what do we mean by assertive communication?
Be firm. Get your point across.
Okay, be firm.
Be polite and firm.
Be polite and firm. Okay.
Confident and
with no aggression, with no emotion.
With no aggression. With no emotions, or no aggression is better.
Yeah,
Emotions is okay. I was asserting when I was talking to Minnie and Manju, but I was not emotionless because I knew it's only through emotions I can calm them down if I want to align them. What else?
Transparent, that results, everything should be
Transparent. So if you are transparent, you are not faking, you are not hiding anything, you're not deceiving the patient party. So they can make out. What else?
Respectful.
Wonderful. Respectful. Yes, that's very important. Usually we become aggressive and we become disrespectful. And that is where the communication starts breaking down. What else? Do we stick to our point?
Yes.
I request you to delete this particular understanding of assertion. Humble request to all of you. We don't stick to a point. We make our point with 5 things: open, honest, positive, confident, respectful.
Once more, ma'am.
I repeat, we make our point by being open, honest, confident, positive, respectful. And when we make our point, we listen to the other person with equal amount of attention. So when Manju and Minnie were not ready to listen to me, and I could see that they are so aggressive and overwhelmed that they were not allowing me to speak, I asserted. I said, yes, I understand you have a lot of concern, but if you will just keep asking me questions and if you will not let me speak, I will not be able to address your concern. So it will be good if you say something, listen to me, and then take your own time to, talk, but then let me answer your question. So I spoke, I asserted, and then I also listened to them with a lot of intention and attention. So when you listen to the other person's point of view, for example, if Minnie or Manju had said that we have exhausted all the funds, if you can keep my patient free, it's okay. Otherwise, we want to move the patient to government hospital. Now, do I still stick to the point? No, don't take the patient. No. Then I have to either help them understand that why it is better to let the patient be here under our care, or in case if they think they have already exhausted their funds and you cannot treat them for free, maybe you can waive off your consultation if you decide to do that. But the hospital charges you cannot waive off. We don't have authority to do. So there I'll have to clearly communicate that, see, I can waive off my charges even if I want to do that for you. I can do that for you, but what about the hospital charges? That's not in my hand. I can't waive off that. And nobody will do that. In that case, I will have to understand their concern, because none of us would have some fixed amount in the bank that, okay, this is my medical expense charges. Do you have anything, something like this with you? Anyone? I don't have, honestly. So people just arrange funds when they fall sick. And there will definitely come a point when they've exhausted all their funds. So in that situation, I mean, a point might come, then I'll have to say that I think if you really think you can't afford, then I think it's better if we ship the patient to a government setup or wherever you can afford. And I'm ready to cooperate with you. So in assertion, we are not adamant on any point. We listen to the other person, and if the other person's point is valid,
Amenable to suggestions.
we accept that. Okay, I think you're right. I'll go by what you are saying. I understand. That is assertion. We normally think when we are firm, adamant, authoritative, that is assertion. That's an absolutely wrong definition of assertion. We really need to delete that understanding, because that is not assertion. That is subtle aggression.
Yeah, that's right.
So let me show you the last video and let's see, could she have handled it in this manner, the same situation? I think it's taking time to upload. Let me reload it, please.
मैम मेरा नाम एप्लीकेशन जाने के लिए मैम आ रही है मैम मेरा नाम एप्लीकेशन जाने के लिए जा रही
कहाँ जाना चाह रहे हैं?
दूसरे हॉस्पिटल
छुट्टी के लिए कह रहे हैं?
हाँ जी
जो उसका बेटा बेटा जो साथ में वही होता है उसका। भेजो उसको, मैं एक बार इसी बात। भूपेंद्र नाम है ना आपका? आप उनके बेटे हैं? क्या हुआ उनका? जी मैम डिस्चार्ज कर दीजिए। कहाँ ले जाना चाहती हैं? जी मैम किसी दूसरे हॉस्पिटल में जाएंगे जो अपने पास में होगा। वहाँ से आने में बहुत दूर पड़ता है और जो पैसा है उतना है नहीं मेरे पास, जाने का खर्चा बहुत हुआ। देखो बेटा, अगर आप कहोगे छुट्टी कर दो मैं कर दूंगी, मुझे कोई दिक्कत नहीं। तो मैं आपको ये बताना चाहती हूँ कि इस वक्त उनकी हालत जो है वो लेके जाने वाली नहीं है। क्योंकि एक तो जैसे यहाँ से अगर आप लेके जाओगे तो रास्ते में एम्बुलेंस में लेके जाओगे तो कैसे होगा कुछ नहीं कह सकते, क्या सिचुएशन में कुछ नहीं कह सकते, मतलब हालत इतनी अच्छी नहीं है। ठीक है, थोड़ी भी ठीक होती है तो मैं कहती चलो ले जाओ, कोई बात नहीं। तो एक तो सबसे बड़ी बात ये है। दूसरा ये देखो बेटा, जैसे पिछले हफ्ते से हम लोग इलाज कर रहे हैं, हमें काफी हद तक उनके बारे में पता है क्या उनकी कंडीशन है। अब नए हॉस्पिटल जाओगे नए सिरे से वो इलाज करेंगे, मैं बेशक मैं पर्ची बना के दूंगी, उनका सारा डिस्चार्ज लिख के दूंगी जो ट्रीटमेंट करेंगे। तो फिर भी एक होता है डॉक्टर जो ट्रीट कर रहे होते हैं उनको पता होता है कि इस वक्त ये किस दवाई से इनको फायदा हो रहा है, क्या इनको नहीं सूट कर रहा। नई जगह जाओगे तो फिर वो नए तरीके से सारा हैंडल करेंगे। तो देखो एडवाइजेबल तो नहीं होता बार बार डॉक्टर चेंज करना, और मुझे ऐसा भी लग रहा है कि पिछले 2-3 दिनों में थोड़ी, अगर आपने नोट करा तो उनकी कंडीशन में इम्प्रूवमेंट भी हुई है ना। इम्प्रूवमेंट तो नहीं, बट उनकी पैसे वाली प्रॉब्लम आ जाती है। पैसे देखो बच्चे, ये तो मैं मानती हूँ कि प्राइवेट में तो खर्चा आता है, अगर जहाँ भी लेके जाओगे वहां भी खर्चा तो आएगा ही आएगा, ऐसा तो है नहीं कोई फ्री में हो जाएगा। अच्छा, सरकारी में अगर जाओगे तो वहां पे आपको पता है वहां पे इतना पेशेंट होता है कि आपके पेशेंट को बेड मिलेगा नहीं मिलेगा कुछ गारंटी नहीं है ना। देखो मेरे से पूछोगे अगर तो 2-3 दिन की बात और है, जहाँ इतना सह लिया ये भी आप कर, बहुत मुश्किल है। लेके जाना चाहते तो बेटा मैं जिद तो नहीं कर सकती तुम्हारे साथ में, तुम्हारा पेशेंट है, तुम्हारी फादर है, तुम्हें डिसाइड करना है कि क्या करना, जो भी करना था तुम कर सकते हो। मैं पर मैं कहूंगी ये कि घर पे एक बार सलाह कर लो, अपने बाकी जो लोग हैं उनसे बैठ के सलाह कर लो, क्योंकि मेरा कहना ये कि 2-3 दिन की बात है, जहाँ हफ्ता निकल गया फिर भी कहोगे तो मैं कर दूंगी छुट्टी, मुझे कोई दिक्कत नहीं, मैं पर्ची बना दूंगी, पता कर लो जहाँ बेड है इतना खर्चा कम, जाने ले जाओ। वैसे आपने सही कहा, मैं एक बार जाके घर में मैं डिस्कस कर देता हूँ मैम, और पता करता हूँ कि 2-3 दिन की और बात है, और इम्प्रूवमेंट भी अच्छा हो रहा है उनका, तो शायद हो सकता है कि खर्चे को एडजस्ट कर लेंगे तो हो सकता है सही हो। देखो बेटा हॉस्पिटल में खर्चा तो होता ही है, ये तो है नहीं कि फ्री कहीं काम होगा, वहाँ सरकारी में जाओगे तो वहाँ टाइम ज्यादा लगेगा या बेड नहीं मिलेगा, प्राइवेट में जाओगे तो 19-20 का फर्क आएगा, ऐसा नहीं क्योंकि जमीन आसमान का। फिर भी आप सलाह कर लो, मुझे बता दो, ठीक है। थैंक यू। So I hope you got some idea how we can assert and strike conversation with the patient party. Any comments on anything on videos or the discussion that we have had?
What should be the ideal scores?
Sorry, what should be the
What
ideal
should have
score?
been the ideal scores?
So I'm sure all of you have got higher score on assertion, and you all must be very happy that we all assert. Happy? Anybody who has not got highest on assertion? All of you have got highest. But there is slight
Last one. Yeah.
There is slight twist. The twist is we normally assert, so therefore our highest score is assertion. But when things become difficult or when we are in a conflicting situation, our second highest score style is more likely to come in picture.
Sorry, didn't get you.
Okay. So I'll just
second score.
Yeah. For example, if I may look at okay, Dr. Asha's score. So her score is 20, assertion is 20, which is very good. But if you look at her passive and aggressive score, that's 14 and 15. That means she will try assertion, and if assertion does not work, she's likely to either become passive or she's likely to become aggressive. Do you agree with these scores? So similarly, Dr. Rakhi, you are more likely to use assertion and aggression alternatively, depending upon the situation, because your assertion and aggression score are more or less neck to neck, 14 and 15.
Yes.
So you will try assertion, or you may even pick up aggression as a way of communicating. Do you agree with your scores?
Yes, ma'am.
So Dr. Vasudevan, even your score says that you normally use assertion in most of these situations. And if that does not work, there's a possibility of you going for passive aggressive style. These are your scores, not me who is talking.
Madam, if assertion doesn't work, which should be better?
Actually, we should stick to assertion as much as possible.
The second one, second option.
Like if I may say, if I look at the scores of Dr. Hari Mohan. So you see, his highest score is 20, which is assertion. And other three scores are not very high, 9, 5, 8, which is okay. So that means in most of these situations, he would be using assertion as his way of handling difficult conversations. If you look at whose scores do you want me to see? Okay, Dr. Menon, in your case, you're going to try assertion, but if that does not work, you can either become passive or you can become aggressive, again, depending upon the situation. These are your scores that I'm just kind of giving you interpretation. So I hope you have some idea about now your communication style. We have to actually, learn assertion. It's a learned skill. It comes with a lot of practice, but once you have learned it, then that becomes your way of interacting with everybody, either at personal front or in the professional arena. We would be using the same style more often than not. Any questions about what we have discussed?
I think one point I'd like to make is a bad habit that I have, especially when communication, being careful with your hands. So sometimes I go this or point, and that can often be taken as a sign of aggression from our side. I think we should be extremely mindful of our body language.
Yes. I completely agree with you. So especially when you are handling such difficult situations, if I may tell you briefly about verbal, non-verbal, and body language part. So most important, the first one is language. Throughout your assertion, make sure that your language is respectful. Even if the other person becomes aggressive or uses disrespectful language, if you will stick to respectful language, the other person will automatically realize that you are not reciprocating. Aggression fuels aggression. If you are not aggressive, now for example, Dr. Minnie or Dr. Manju could not be aggressive with me because I was not neither aggressive nor passive aggressive. I was asserting and I was also aligning myself with them. So naturally, they could not see any reason to become aggressive with me. So the first thing is language. Second is tone of voice. So tone of voice have to be professional, audible, neither very high nor very low. If I'm low, I will appear inconfident. If I'm high, I will appear aggressive. Even the speed of speaking, normally when we are upset, our speed increases. Very mindfully, you have to keep your speed of speaking to either normal or even little slower than. It becomes more impactful when you slow down in explaining. It puts weight to your words. Then facial expressions, in that eye contact is very important. Make eye contact with the person with whom you are talking. But of course, eye contact should not be intimidating. It should be of care, concern, compassion. Facial expressions, again, it should neither be pleading nor it should be threatening. So facial expressions have to appear friendly but professional. When I say friendly, I don't mean pleading. Please do, you have to understand, this is not the way to behave. No. I would have not authoritative facial expression, but professional. Sometimes even keeping your face slightly blank is okay rather than having pleading or threatening expressions. It's always good to sit and talk. If you remember, Dr. Harigon was saying that it's always good to sit and talk because when you sit down, your energy to fight goes down. So that's why we always say if somebody is angry, make that person sit down. Give them a glass of water. That will cool them down. It will give them some breath. It will give them some time to slow down. So these are not just courtesies that we offer, but this is the way to cooling the other person down. Make them sit down. Energy. See, when you want to fight, you have to stand up. You have to stand up and your body has to become tight. So when you sit down, you can't fight. So that's why it's always good to sit and talk. Then put that person at eye to eye level. If the person is standing and is refusing to sit down, if you are sitting and you're talking like this, it's going to strain your back. Or other way around, the person is sitting and you are standing and talking, you are going to strain your neck and that person is going to strain the neck. Again, it's not a good arrangement. So it should be eye to eye. Preferably both the parties should be sitting. Then say what you want to say, listen with the same amount of attention and demonstrate attentive listening. So when it comes to demonstrating, like nodding, agreeing, making that sign, yes, I understand, yes, I agree, I can see it. So these things kind of assure the person that you're not only understanding, but you're not only listening, but you're also understanding. And then when the other person speaks, listen to that, allow that person to complete. But if the other person is not letting you speak, that is where you have to assert and say, see, I'm ready to listen to you. I want to help you, but you have to allow me to speak. If you will not allow me to say what I have on my mind, I will not be able to strike a conversation. So you are asserting, but in a polite, in a professional and respectful manner. So 3 things keep in mind. One is your language, which should never go down. Second is your tone of voice, volume, speed. These 3 things you have to keep in mind. And third is your body language. Face the person, sit down, make the person sit down, say what you want to say, listen to the other person, and then work on it in a very open mind, how you can help that person. We are going to have another session on how do you handle complaints or request. So there we will take up another situation where somebody has come requesting for something or has come with a complaint against your resident or against your nurses or some system. So how do you address those things? We will talk in the next session. But this was just to, work on the communication skills that we need to first of all learn, practice, and demonstrate assertion. And when you will start practicing this, your team will be able to observe that you are handling in a very, very mature and calm manner. They will learn from you.
Can I ask you something?
Sure, ma'am, please go ahead. Yeah.
Suppose a patient makes a lot of noise in the waiting room because he's getting delayed.
Yeah.
But once he comes to your room, the cabin, then he's very normal. He doesn't have any complaints. So how do I deal with him then? Do I have to tell him?
So I'll give you an example. So this happened in my clinic. My husband is an ophthalmologist. So there came a patient, and this girl of mine, whom you saw in the video, she's our on front desk staff. So she made patient sleep and she said, "Sir, pay kar dijiye, please pay." He said, "I'll go and see the doctor and then come out and pay." Now the system here is that you have to first pay and then we send you in.
Issue the card.
He says, "Am I going to run away?" So she said, "No, sir, it's not about running away. You have to pay and then I can send you in." So in a very angry way, he threw 500 rupee note and he said, "Take." And he also used a cuss word. He used a foul language. Now this girl called me. I was at home by chance that day. That day I had not gone anywhere. So she called me and she said, "Ma'am, this is how this patient has behaved with me and he's used abusive language." And even she was literally in tears. And these are young people, they're not very used to this kind of behavior. So I felt bad. I don't, allow anybody ill-treating my staff. So I said, "It's okay. I'll come down." Then I went down and I saw he had already gone in my husband's chamber. So my husband was seeing his wife. Actually, it was for his wife that he had come. So my husband didn't know anything about what he has done outside. I went in and then I sat there and I allowed the whole consultation to be over. And then then everything was over. Then I said, "Sir, I wish to talk to you about something." He said, "What is it?" I said, "Sir, you abused my staff." He said, "No, I did not say anything. I did not say anything." I said, "The word that you used is not abuse." He said, "No, it's not an abuse." I said, "Can I use this word for you or for your wife? How can you use this word? How can you use this word?" I said, "If I can't use it for your wife or for you, how can you use this word for that girl?" Then I changed the tone. I said, "See, we are all very fortunate that God is very kind. He has given us everything. But these people who are working for us, they come just for a few thousand rupees. And we can't, take away their respect by using this way of treating them. What have you gained? What have you done? I mean, you would just go away, but her whole day is gone now. She's crying literally." He suddenly got up. I thought he's going to say something. He went out and he said, "I'm really sorry." We have to address, but then we have to handle it very firmly and carefully. I was not disrespectful. I did not argue. I could have gone and started fighting with him. "How can you talk to my staff like this? I will not see your wife. Go. Take your money back. Go to another doctor." But that was not the way it would have resolved. He went and he said sorry. I said, "That's okay." His wife also got really scared that might be he will go and shout at the staff. He also ran outside. He was very cordial. He said, "I'm sorry. I misbehaved with you." And yes, you must address. Don't, because your staff feel demotivated and discouraged if you don't support them, especially if they have not done anything wrong. Even if they have done something wrong, we can explain them later that this was not the way to talk. And we don't have to fight with the patient also, because again, that's not the agenda. But yes, communicating that we will not take misbehavior is very important.
Yeah, you can also tell they have not taken any food in the morning. Still, they are waiting here. They are waiting for your turn, and they are not all the time. They were standing here like that.
So
Also,
if waiting hour in your hospital is a problem, then please work on the system to establish where the waiting hours can be minimized. If you remember the design thinking format that we used, use that format and reduce the waiting hours. A lot of doctors would call the patients and they'll be busy with other patients, and then patients are waiting. We are taking patients for granted. There was a time which was okay when it was okay. Now patients don't like this. You can't make them wait unnecessarily. 10-15 minutes here and there, they would tolerate. But if you make them wait for 1 hour or 2 hours, then nobody is going to be happy with your way of work. Then I need to sit and work on my OPD management. Any other questions about the role play or the topic or the scores? So we have actually covered 2 topics in this discussion. One is handling uncooperative patients, and second is your communication style. So going ahead, if no more questions, going ahead with the presentation. If I may request 3 of you to quickly do your presentation. I'm giving you the rights to share your screen. So who is going to present first?
Ma'am, I need your help because I'm not having.
I will share your presentation when you will make the presentation. So who is making first? Anybody?
I can do.
Go ahead, please. I've given you the rights to share your screen. Dr. Raki, you are doing? Who is doing? Okay, Dr. Asha, go please. Yeah.
Okay, can you all see my screen?
Yes, we can.
Yes. So after a heavy session today, very important topics we had today of handling an aggressive patient and assessing our communication style. We definitely need an ice breaking. I thought it was a time for ice breaking, so that's why I volunteered to do that first. It was a very heavy topic. A lot of I thought of the sessions, one of the most important session was today. I thought very important things we learned today, man. So it is definitely time for ice breaking, I think. So let us do the ice breaking first. I mean, before we start into the topic, can we assess our present mood now? Are we all feeling like putting our brains to sleep, or are we all feeling heavy? That's a feel I feel very heavy, full of information, or too much for one day. The brain is all feeling so full. What is your feelings? Can you all just put in the chat box how you're all feeling? And just be true to yourself. Just be frank. No judgments here, no opinions. Just a word or an emoji or whatever of what you feel right now, your present mood. Tired, drowsy, excited. Yes, the first one is coming. No judgments. All can be free here. It's just an ice breaking. So everybody can be feel free to do your emotions here. Even emoji you can put in, right? Looking at the clock, wonderful. Okay. Heavy. Hungry. Yes. Oh, feeling full and elated, I suppose. The ring is the elated one, I think, right? Okay. So the hoping to finish soon. Hungry. So generally, we got an idea of all the moods. And tired. Yes. I mean, yes. With that, I think we'll go into a short, a session of a rapid fire of a few brain teasers to change this mood. Can I try a series of brain teasers, just riddles, simple, fun questions, which anybody can answer? And there'll be gifts for people too. Can I do a set of riddles? All ready? Anybody can answer, free for all. Okay, simple set of questions just to change the mood. Shall I start?
Sure.
What holds water but has holes? It can hold water, but it has holes.
Oh my goodness.
Sponge.
Yes. Here's a gift for you. I don't know if you can see it. A healthy chickie for you. You're hungry. A chickie for you. I can safely offer anything. I need to give it up now, so I can safely offer today.
They'll come to your home to take it, don't worry.
Yes, it'll reach you home for all you know. What has teeth but cannot eat?
Comb.
Comb. Yes, correct. I can't see who is answering, so hats off. Good. And what is at the end of a rainbow? At the end of the rainbow?
W.
W. Yes, wonderful, wonderful, wonderful. Yes. I'm tall when I'm young, and I'm short when I'm old.
Cigarette?
Sorry?
Cigarette? Cigar?
Yes, cigar. My answer was candle, but cigar is also perfectly well. Yes, both holds good. Yeah. What is black when clean, but white when dirty?
A blackboard.
Blackboard. Yes, yes, definitely. Yes. What can you catch but not throw? Can catch but can't throw.
Cold.
Cold. Yes, right. Common cold. You can catch it, but you can't throw it. What kind of a band never plays music?
Rubber band.
Yes, rubber band. Rubber band. Yes.
Husband, Asha ji.
Okay, so 9 or 10. So the mood is changed. That's all I wanted to do. And I hope I've changed the mood. Should I do it in the chat again to see the mood now?
Yes.
I suppose it is evident from the laugh around. So I'm not.
Yeah.
So I'm not. It's not going to the next share, right? What happened? Slide is not moving.
Yeah, it's stuck.
Yeah.
Slide is happy.
Slide is also too happy to move.
Eyes broken.
You can press next.
Okay. So I changed to the slide. So that brings us to the topic of how the ice is broken. I just tried to break the ice of the heaviness. I just made it to, I wanted to make you all feel light, and I hope I've done at least little to make you all light. So usually breaking the ice is fast starting of a new course when the people do not know each other. And it's a comfortable atmosphere of getting to know each other so that they integrate themselves well into a group in a fun way, not in a, formal or, in separate entities, but they integrate well in a fun way of meeting together and integrating well into the group so that you can open up more interactions. There'll already be small cliques, small groups who are already friends. We'd like to break all that and form the whole, attendance or the participants, all the people who are participating to be a whole huge group so that more of interactions can be opened up and you can get the group off to a good start. And that is the basic purpose of breaking the ice, so that the audience or the participants are more engaged in the session that is going on, rather than a monologue by the facilitator or the teacher, that they become more engaged in the learning process and they contribute effectively to the process so that it fosters a productive learning environment. The ice that is to be broken is actually the stereotype perception of each other. You already have a perception of the others in this thing. You have a bias, an unconscious bias already there. It is this perception, this unconsciously what you've created within yourself is the ice that is to be broken. And it can be broken in the way of questions like we did today. It can be small questions or games or activities or music or whatever. A lot of things can be done. Innumerable things that can be done as ice-breaking activities. Just mentioned a few because it's just an overview that we have today in this 8 or 9 minute session which I'm allotted today. And actually the facilitator should focus on what these people have in common. You will have a diverse group as an audience in front of you. What you should find out is what is common. So it is something which has to engage the audience, the activity. Like today we had a group of doctors, of different age groups. So one common factor I have to decide. That's why I thought of a brain teaser, which can be common for anybody. If it is a diverse group, you have to have something which is common. Of course, you can celebrate the differences too, but it is a commonness that can be used for your ice-breaking activity. Icebreakers can be for a specific purpose. Like it has a clear purpose sometimes. For example, it can be opening a topic for session. Like we had Lata ma'am do last session for her brainstorming, her pedagogy of brainstorming. She introduced the topic through a brainstorming. It was hospital violence, and she made ideas from the audience, and that is how we introduced the topic. That is how icebreaker is being used as an opening a topic for the session. It can be a brainstorming for ideas. Like if you're planning a meet for a larger event coming up, you can do this as a breaker. You can share the ideas openly with free opinions, no judgment, no biases, no pros and cons, just open free discussion is what icebreaking is about. And sometimes you can even use to assess the emotional status like I did today. That is just my addition to it. Icebreakers can be fun too. like we had today. We are already into the 6th session. We have almost crossed halfway of our learning process. So there's no need for introductions now. So today's ice break was basically for fun, when we already know each other, to relax, to laugh or talk together, or even to take a break. Like, for example, physical movement. You've been sitting for so long. A simple physical movement, a jig, a dance, an exercise pose, or whatever, that itself can be an icebreaker, or it can be to energize. And it has been a heavy session. And then that is what I intended today. It was a heavy session today. So I just wanted to energize so that we are ready for the next session. Or if the coming up topic is a very important topic, you can energize the people so that they are ready to receive the big topic coming up. So to summarize, the benefits of icebreaking can be, it relaxes sometimes, it engages the audience beautifully, it integrates the participants between themselves, it sometimes energizes us like we did today, it evolves or it improves the team spirit, and above all, it sheds your inhibitions so that you open up more freely. With all benefits done, as in any pedagogy, you have its negatives too. It can be very challenging. It needs a good leader or a good facilitator with a lot of creativity, because it needs to engage the audience. You need to get the pulse of the audience there to put in an activity which they enjoy or which they involve in. Only then the activity becomes a success. And you need good adaptive skills too. If the audience is not interested, you need to change it. Instant changes are needed. So you have to have a good adaptability skill to be a good person doing an icebreaker. It can be challenging in diverse groups. When you have people of 5-year-olds and an 80-year-old sitting in the same audience, how do you find a commonness? Very difficult. There are ways of circumventing that. But in this short session, I'm not going to the details of that. There are ways of it, but that is one of the negatives. Diverse groups can be difficult. Large groups, 200, 300 in the audience, there's not enough time for activity for all. That can be a big negative in icebreaker. So that if it is poorly conducted, it can not only be ineffective and boring, it can be just a waste of time even. With that, before we say thank you, can we all have a group photo session, ma'am? I requested last year. We've never had a group photo.
I know.
I'll stop sharing so that we are all back on screen and do a screenshot.
Bilkul. Let everybody have their camera on.
In an energetic mood, I'll say 1, 2, 3. We all say yo, and then go to the screen.
Dr. Menon, are you there?
I am.
He's very tired.
Already, nobody looks tired now anyway. Good. So
Okay.
I say yo, and all can do the print screen. I don't know my print screen will work or not. All can do a shot. Okay. So
I'm taking for everyone. I'll share in the group.
Yeah.
Okay.
But we need you also. We need you also.
I'm there. Okay. Yeah.
So get set.
Only thing is, I think Dr. Vasudevan is not in proper light, so I'm not able to see him clearly. I think he's traveling.
I am traveling. I'm traveling.
It's okay. I think we'll take a picture and another one next time. Sure.
Okay.
Should I click a picture?
Okay. So get set, go.
Thank you.
Thank you.
Very nice.
Thank you for wonderful presentation.
Very nice, ma'am.
It was, I think you had really done a lot of preparation for this, I would say, and you're a seasoned trainer, so I'm sure you must be comfortable doing this, but it was very well done. This is what is expected, that each one of you should be able to do your trainings in the same energetic manner. Thank you.
Yeah.
So people are complimenting you for your excellent presentation.
Really.
Yeah, thank you. So we have Dr. Rakhi and Dr. Minnie. So Dr. Rakhi, will you present now?
Yeah, I will.
Go ahead, please. Yes.
Okay, how to share screen. Okay, is my screen?
Yes, we can see you.
Okay. Good evening, all.
Very
So-
good evening.
Good evening.
Yeah, so now
Good
you
night.
know that is Indu ma'am
It is
handling
good night, madam.
difficult audience. Okay. Yeah.
We
So
are
I'll tell
difficult
you
audience.
my first memory actually of difficult audience is being in an audience in a classroom, of course, while the teacher would be teaching me and we are all students, like, and the teacher comes in and says, silence, silence. That's the first memory of me. And then standing in front of an audience itself brings jittery, to my spine, and it is worse than my worst fear. So my hope and prayer is that none of us would have to face difficult audience. Okay, so let me tell you, after so much of research done by a lot of public speakers, they've gathered information and they've collected, and after a lot of research, they've come to conclusion that there are 5 types of difficult audience. So the first type, as you can see, these are all the types, okay? The clown, the snipper, the snowman, the black cloud, and the unwanted panelist. So I don't know whether I'll be able to do this as a quiz for you all. Like, this is the clown. So anybody can tell me what the clown audience would be doing, or, clown what?
So maybe we can all write it in the chat box. We can write it in the chat box. Yeah.
Yeah.
Distracting.
Yes.
Yes, absolutely.
Yeah.
And
trying to make it
complicating.
No, he's like, what the clown does, like, distracting, of course. How he could be chatty, talkative, and extremely overexcited. Okay, so he'll be all ready to entertain you. And I was telling Indu ma'am, I'm in the clown audience, I'm the correct example. And so coming to how to handle them. Use their energy skillfully. I'm going into the thing because I don't know whether I have enough time to ask you more. So what do you mean by using their energy skillfully? Anyone? Because you can, anyone?
The clown of themselves.
Exactly. You have to make them, get involved in the talk. You can ask by asking them to give, you can ask them whatever they want to say, to give them good eye contact, okay, and keep them from monopolizing. But you cannot be, it shouldn't be a one-man show. Like these kind of people, what they do, they would want to keep talking. So you have to prevent them from monopolizing. You know how? As soon as they stop, immediately you should take up and you say, yes, that's it. And you should make them quiet and just, make them sit. Okay, that's one way. Another one is to use a light, positive touch. Like, you can keep a good atmosphere in the room, and you can never be serious when these kind of people are there in the audience. Okay. And you can laugh with their jokes and allow the audience to enjoy it as well. But always put the focus back to the topic, what you're trying to say. Okay. And the next is to focus on the purpose. So if you need them to be more calm or serious and get them on track, gently by mentioning the purpose of your talk and how you would like the audience to behave. That is the last thing you could just tell them, okay? And the next is the snipper. So these kind of people are like, they're individuals, they're trying to win a point, or they want to be the showstopper, like, so they're always interrupting, arguing. Okay. So these kind of people, how you can handle them? Snippers. Main thing is fear not. You should never, when people are trying to, it will be like you standing and then the, bullets are coming onto you. But then what you need to do is fear not, because you should remember that you are standing there on a purpose for a reason. Okay. So don't ever feel uncomfortable tell yourself that you are prepared, and you have to be prepared, because you have to be, the topic and the subject, you should be thorough. So then you can be standing there, chhati upar, gardan piche. Yes. And the next is, fear not. And the next one is, don't take anything personally. Okay, so these people will be asking you all sorts of questions. Can this happen, ma'am? Can that happen? So that time you should not take these things personally. Just, relax and just talk to them properly and welcome them. That is the next thing. You don't get offended as to why they're asking me such a question. Just welcome them, okay, and listen to them properly, and don't argue, okay, and provide a reasonable evidence to support what you're trying to say. Okay, that is, I think, and always, as an old saying says, you win an argument and lose a friend. So you don't try to, win an argument with that person. Just tell him and, be happy. The next is the snowman. And you all know what snowman does. Whatever you tell, he'll be just, the snowman is sitting there. Okay. So how much you talk to snowman, they won't respond. But okay, they're silent and they're socially anxious. That's what they say. Or maybe I'm thinking this snowman type of audience, they are some electronic device enthusiasts. They must be chumma sitting there. So how to handle them? But I'll tell you, never assume that this silent snowman kind of audience is not reflective people, okay? Because they can be like, they are highly reflective people. They try to sit there quietly, but they might be absorbing everything. So even though you're not getting any immediate feedback from them, it doesn't mean that they're not enjoying your whatever you're saying, okay? So, and then the next thing is, you have to be welcoming. So try to warm them up by welcoming them with a smile or creating a positive atmosphere, and you could start gently with an interaction. That is how the snowman can be. And then ask them for their insight, because there's too much sitting in one corner, like, then you have to ask them for the insights, what they think about the subject. So these insights could be useful for us also in the long run, okay? And the next type is a black cloud. So these black clouds, as the name suggests, they come with a negative body language, like a frown, they slouch, and they sit and arms folded, and and they never give you a good eye contact. So it's because they have a I can't do this kind of attitude. They're thinking that, okay, this is too this subject is not what I want to do, or it is too difficult. These are the kind of things they're thinking. So what you do with them, you have to get creative. You have to engage, like how Asha ma'am was saying. You have to find fresh and new ways to engage them and to get them involved. Okay, and the other thing is to be enthusiastic. So these people are all in a negative thing. So you have to bring more extra sunshine to this black clouds. How you will do that? By showing extra enthusiasm towards the topic, and reassure that the subject that may seem difficult for them can be made easy, just like how I'm doing right now, isn't it, Indu ma'am? Okay, and then you have to be supportive. You have to be patient, and you have to encourage them, saying that you think this is not this topic is difficult, but I can help you, I support you to understand it. Then the next one is the unwanted panelist. In every group, you will have people who will say, yes, I have a question. Okay, so why they're doing that is because they have considered themselves as experts in the room. Okay, so they try to add to your knowledge by trying to teach the audience with his or her experience. Okay, so these people are really a potential danger to the speaker's credibility, But the good news is that even the other audience are also thinking that he is a little irritating. Why this man is going on asking questions? Why can't he just shut up? And that is what. So that is the good news for us. So how to handle them? You have to set expectations. You have to, first of all, you have to be clear and say that, so, okay, I want my audience to behave like this. And if you have any questions, I will answer in the last or something like that. You have to set expectations in the beginning. Then you have to remember that you are in charge. Okay. So you are in charge, and by calmly reminding him that he, whatever he has to say, I will deal with him later, or you can talk to me after class. Okay. And finally, okay, before that, I'll tell you one more thing. If you focus on sharing an authentic message that you believe in, no matter what, you will find a way to make the audience connect with you. Okay. So if you are true to yourself, and you will attract the right people who can benefit from your message. Okay. And whenever a group of people assemble, different personalities are present. Okay, I think that's it. And now the kind of pedagogy that I used in this way of presentation is a Socratic questioning. Actually, I wanted to do that, but because of lack of time, otherwise I wanted to create an active classroom. Okay. And I wanted you people to start thinking, and in that way it can deepen the students' understanding. I hope you people have understood what I tried to tell you today, and it encourages, you can analyze it later. Okay. So it will inspire student, all that. This is the Socratic questioning. That is the kind of the quiz type of presentation that I did today. So the advantages is it actually develops the critical thinking skills. It encourages. Yeah.
Hold on. I think we are going out of the scope of the topic.
No problem. No problem.
We have covered till that point. That is okay. Even this is not required.
Yeah. Okay. No problem. Thank you so much. Thank you. Thank you very much. Yeah.
Thank you. Thank you for the presentation.
Okay. Stop share. Okay.
Yeah. Thank you so much. Thank you. Any questions for Dr. Rakhi?
Yeah. Anything?
I think we made her play that role of, difficult. We made her face difficult audience. If you remember, Dr. Rakhi, we had sent you out and we made you do the presentation, and everybody acted.
Yeah. Exactly.
So you have taken full revenge with them.
That's true. I hope all of you all could at least get whatever I was trying to say. I don't know.
Absolutely. We got to know the different types of difficult audience and how do you go about dealing with them. I will request everyone to share their presentation in the WhatsApp so that everybody can have a look at it, after the presentation.
How do you do that?
You can do that. That's not a problem. Don't worry. I will do it on your behalf if you want, if you have difficulty. So we are left with Dr. Mini. I know it's 10:30, but I think these sessions will be slightly lengthier because we need to cover two things. One is the topic and then is the presentation, and both are equally important. So I will request Dr. Mini to do the presentation. I will share the screen for you. Dr. Mini, do you want me to start?
Yeah, because I am already from the hospital.
Okay, 1 second. I'm sharing the screen. Give me 1 second. Yeah.
First slide, second.
Okay, give me 1 second. Yes, go ahead, please. Yeah.
Yeah, now it is already 10:30. It is time for a lullaby story time. And all of us are very fond of stories, for fairy tales and all. Now, hope all of you must have visited this famous monument, which has been built as a token of love by the great emperor. And all of you might be having such romantic photos in your albums too, isn't it?
Yes.
You know what is the story behind this? It is built as a token of love by the great emperor
Shah Jahan.
Shah Jahan. And
Memory of his wife.
yeah, yeah. But why? How did she die? You know?
She was killed.
Huh?
He killed her.
No, she has died of postpartum hemorrhage. So even in those times, bleeding was one of the cause of maternal mortality. So that is why I've taken this topic, maternal mortality, this slide and this
Childbirth.
story. Yeah.
Childbirth,
maternal
She
death.
died.
Yeah, died of postpartum hemorrhage during her delivery. That is why we gynecologists are very famous. We are fond of this famous photo. Okay, and this is a token of love for her by her husband. Okay, we don't know how much romantic our husbands are and what we will be having. Okay, so storytelling is actually a two-way interaction. It can be written or oral, and someone telling a story and one or more listeners are there. It is a well-known powerful means of communicating messages and also of engaging the audiences. In simple words, storytelling is a description of ideas, beliefs, personal experience, life lessons through stories or narrating something which provokes the insights of the patients. There are many forms of storytelling. It can be earlier one where the oral storytelling, we have a lot of fairy tales. The next were written, we are all fond of writing stories also. And now the latest digital method, we have so many videos for children and for even for the business activities also. So storytelling is a very important form of communication. And how can we use that? You can use it as a beginning, at the beginning of your talk, just by narrating a story, or you can use in between the talk or as a takeaway message, or you can also use inclusive storytelling where you make all of us, all of the audience, all of the people to bring out their own stories or engage them in this storytelling. And you should know your audience. You should be thorough with your goal. You should choose the right time and the right place. And you should be clear and concise. And you should be aware of your body language and should also practice very often. You should make stories that are meaningful to the wider audience. The best stories are not only interesting, but engaging and also meaningful. It should be authentic also. It should inspire the readers through your stories. And it should be neutral. It should create curiosity. It should be neutral in the sense, it should not bring out any religious or some other insights into that. It should not go against anything. So it should be neutral. But don't switch away from the point of view. Don't create any flat characters. And it should not be time consuming also, because it should cover the point only. It should not be crude or offensive, and it should not be very complicated. It should be very simple so that the message will remain in your mind. And the advantages are, it should be gaining verbal skills. It increases the imagination and memory skills of the person, listening skills, and the concentration power. It brings the confidence, and it is a powerful method for building empathy and community, as well as for teaching active listening, writing, and speaking skills. But the disadvantages are that audience and the storyteller can be easily distracted because we may deviate from the main point of view. There is less chance for questioning, there is less chance of active participation, and lack of learning by doing things, making them doing, and it might be monotonous, and you might get easily distracted. So how does storytelling enhance communication? Storytelling actually is a function in the brain that is called neural coupling. It enables the listener to convert the ideas presented in the story into her own ideas and experiences. And this makes the content in the communication strategy more personal and relatable. So stories which come from the heart is actually a powerful method for building empathy and community. The most effective way to engage an audience is with a storytelling. In fact, human brains are specially wired for that. The best communicators today are the ones who engage with the audience on a personal level, invite them to hear the story and ensuring that it lives up to their expectations. So master your skill, you will be very well on your way to become an effective communicator. And the best way to teach is by storytelling. A simple story. Thank you.
Thank you, Dr. Mini. I think that was a very good presentation. I can see some message in the husband has bought the land, rest is with the wife. So I think, thank you so much. I think all of you are doing wonderful, job. Plus you are taking pain, you are making effort. I think that is something I appreciate. You're not taking it lightly. You're all connecting with me. I really appreciate that you are trying to make efforts on doing your presentation well. And plus, you're also sticking to the time. If I'm giving you 7 to 8 minutes time, actually you are able to do in those 7 to 8 minutes. That's something I really, really appreciate. Any questions to any one of us, me or the 3 presenters who have done? I know it's very, very late. You're all sleepy. I can see half eyes closed. I'll not hold you further. I'll share the feedback form in the group. I request you to give the feedback, not on their presentation, but on the topic that we covered, handling uncooperative patient party. That's all. Thank you so much. Good night, everyone. Bye-bye.
Thank you.
Thank you.
Good night.
See you next week. Yeah.
Share the photo also.
I will do that. Sure.